Hi guys, good evening. I hope we are clearly visible and audible to you. Just give me a thumbs up if you can just see me clearly. Yes, we are live now, and just to address that particular query, I just wanted everybody to be sure of the fact that we are having this particular session targeted for the FMG June exam. So as some of you were making a comment for the fact that this is not for INI-CET. We had the INI-CET session yesterday by Govind sir for pharmacology. So we are going to be having regular in-app live sessions, and this is going to be the first session so far as the FMG June exam is concerned. Right? Hi Dr. J, hi Dr. Anonymous, Dr. Anuj. Yeah, this is for FMG Dr. Anuj Sharma, don't worry. Yeah. Hi Dr. Malika, hi Dr. Rajesh. So we're going to be having this particular session, and yeah, so we expect the exam to take place somewhere in June, and therefore we have a good enough time for us to revise all the 19 subjects. Very shortly we'll be discussing the schedule of the regular live-in sessions with you. I just want you to just be familiar with the course that you have read with, and just be with us for this short duration of time wherein we can have a very quick revision about the most important and the most relevant points pertaining to your exam. Right? Yeah, hi Dr. Bhavna, hi Dr. Ankit. Alright. So I can, hi, very good evening, Dr. Praveen sir. So Dr. Praveen Tripathi is also joining us, and so good to have him supporting us, right? So I hope the system is working pretty fine, and we are very much good to go. Let's have a discussion. So what we are going to be doing is we are going to be having a discussion of the most important points. Just breeze through these points with me. I intend to keep most of this session in English only, but just in case intermittently I speak up the other languages, please bear with me. And yes, so let's start the session. We're starting off the session with something like general pathology. I hope most of you have started watching the videos on the Cerebellum app as well, and some of you may have read about these topics from any other source as well. That doesn't make a difference to us, but main purpose is that you have a quick revision about what is likely to be asked in exam, and let's just breeze through the important points. So just starting off with the important points. The very first topic I'm going to be starting off with is going to be general pathology, and I'm going to be starting off with cell injury. So what you just need to remember and revise over here. Thank you so much, Dr. Kavi. Best wishes and warm greetings coming in from students who have cleared the exam earlier. So thank you so much for keeping in the faith. We are going to be having a discussion about cell injury. If I just have to kind of help you understand and revise the fact, the commonest cause of cell injury, I believe most of you should be able to answer that very, very comfortably, happens to be hypoxia. And different questions that are put up to us in the exam. So many times I have discussed with you the kind of hypoxia. I just want you to answer that in the chat box. The kind of hypoxia which is you associated with a patient who's going to be suffering from carbon monoxide poisoning. Just very quickly answer that. Right, the kind of hypoxia that you associate with a patient who's supposedly suffering from carbon monoxide poisoning is going to be, yeah, carbon monoxide poisoning. Yeah, this is likely to be helping you with INI-CET, Dr. Manas, but and considering the fact that the FMG exams is going to be having relatively easier questions depending upon the time that you have, just be familiar with it. I mean, I just don't want you to waste up your time over here. If you're specifically targeting the INI-CET, maybe some bit of questions here and there, yes. So we are talking about something called as, yeah, carbon monoxide poisoning is going to be associated with, please remember the fact that's going to be anemic hypoxia, right? If I'm talking about cyanide poisoning, then you need to remember the answer as cyanide poisoning is going to be associated with histotoxic hypoxia. So please don't goof up on that question. I still find a lot of people answering that as hypoxemic and people saying histotoxic. Carbon monoxide is going to be an example of, remember the fact again, that's going to be an example of anemic hypoxia. Now, if I talk about the development of injury at the level of the cells, there can be an example of what is given the name of a reversible cell injury. So far as the earliest feature of reversible cell injury is concerned, that is going to be hydropic change. I want you to answer in the chat box, what is the example of a tissue which is going to be showing you fatty change in case of reversible cell injury? Yes guys, please, very quickly. Example of a tissue which is going to be showing you fatty change when there is going to be a presence of reversible cell injury. Yes, very good. Yeah, just try it out. So any kind of a tissue that you read in biochemistry which is going to be associated with lipid metabolism, primarily what we intend to talk about over here would be tissues like the liver, and we talk about the cardiac tissue. So liver and the heart are going to be showing you fatty change, whereas other tissues are going to be showing you hydropic change. That is what I wanted to be familiar with. For the question that is put up to in the exam with regards to the involvement of the myocardium, if you have watched the latest 2023 videos, I would be asking you to be getting familiar with the fact that you're going to be having the presence of what is given the name of a tigered myocardium. So tigered appearance of the myocardium is what is going to be associated with the fatty chains causing an involvement of the cardiac tissue. That is what you need to have an idea. Please don't expect that the questions in the exam are going to be straightforward or they would be repeat questions always. The examiners can actually try to test your basics, and hopefully, I mean, I personally have no issues if in you watching the old videos as well, but then obviously if you're going to be keeping an updated eye, then that's always going to be better. So fatty chains, hepatic tissue as well as cardiac tissue, right? If I'm talking about irreversible cell injury, that is going to be contributing to the development of cell death. Now very quickly you need to answer for me, what is an example of a condition which comes to your mind if I'm saying that a patient is going to be having the development of a caspase independent programmed cell death? Can you just let me know what is the type or mechanism of irreversible cell injury I'm referring to over here? Caspase independent programmed cell death. Yes guys, very quickly. Yeah, we are having almost like 200 people over here, so I would expect you to answer that correctly. Hi, good evening, Dr. Positive Vibe. Yeah, caspase independent programmed cell death is other name given to which pattern of irreversible cell injury? I'm asking you a question asked in the exam 4 years back. Yeah, caspase independent programmed cell death is other name for. Pretty good. Srishti is the first one to answer that correctly. Thank you so much for answering that correctly, Srishti. So we're going to be having a process that is going to be given the name of necroptosis. That's what you need to remember over here. If I would have added the word over here, caspase dependent, let's say the question would have been caspase dependent programmed cell death, then your answer would have been obviously apoptosis. But over here we are talking about necroptosis. Please don't confuse it with necrosis, Dr. Joe, Dr. Rajesh. I just wanted to be familiar, Dr. Sharik. Remember, yes, very good. So just be familiar with that particular fact. Now, having said that, the commonest example of an irreversible cell injury which is put up to us in our exams happens to be something which is given the name of necrosis. Almost all salient features of necrosis which I have jotted down for you over here. So I just want you to remember and revise over here, which is the commonest pattern of necrosis that we expect to find histologically. Commonest pattern of necrosis that we expect to find histologically. I just would be talking about the points. Please make sure that you just remember them. That's coagulative necrosis. I did make a mention of the fact coagulative necrosis can be seen in almost all organs of the body with the only important exception, and that is we are using a brain. So CNS is not going to be showing you coagulative necrosis. Hi Dr. Vinash, hi Dr. Sahil, thank you so much. So when you're talking about CNS is going to be showing you what type of necrosis. It is going to be showing you liquefactive necrosis. Clinically, the more important example of a liquefactive necrosis that we need to remember over here happens to be infections. Any tissue which is going to be having either fat or presence of lipase is going to be showing you fat necrosis. So whether I'm talking about the injury to the omentum, to the breast tissue, or for that matter I'm talking about the presence of a peripancreatic fat, that's going to be showing me fat necrosis. Caseous necrosis, a term that you reserve for tuberculosis, right? I just wanted to expand that particular thing for me. Fibrinode necrosis, what are the three common causes? They gave you a question in the All India exam regarding this particular question. So they give an image-based question in the recent exam as well. So what is AIM? Just three important causes of fibrinode necrosis. At least these three causes which I wanted to be familiar with. I'll talk about the exact question which they gave you in the exam. So A stands for an example of a condition that's going to be given the name of Ashaw's body. That's what I wanted to be familiar with. Ashaw's body. I stands for what they love to ask you in the exam time and again. I stands for immune complex disease. Immune complex disease. M stands for the fact the patients are going to be having a very high blood pressure. That's going to be given the name of malignant hypertension. So your aim is to crack the exam. I just want you to remember that fact. Ashaw's body in a patient suffering from rheumatic fever, rheumatic heart disease, particularly acute phase. That's what I wanted to be familiar with. Immune complex disease and malignant hypertension. Three conditions where you expect to have fibrinoid necrosis. Right? Thank you so much, Dr. Medico. Thank you so much. We expect you to, somebody congratulating because he passed the exam, December exam of FMGE. So we expect you to crack the NEET PG exam as well as early as possible, right? Now, when you talk about immune complex disease, this is going to be an example of a type 3 hypersensitivity reaction. Easy for you to remember. AIM has got 3 alphabets. So type 3 hypersensitivity reaction. And one of the examples of type 3 hypersensitivity which was asked in the recent exam as an image-based question was polyarteritis nodosa. So polyarteritis nodosa is going to be having what type of necrosis? That's fibrinode necrosis. Remember and revise for me an example of a micro question. Polyarteritis nodosa is having an association with which type of an infectious organism? Very quickly. The more you are going to be answering the questions for me, the better it is, and the more we are going to be able to revise the points. Polyarteritis nodosa associated with which infectious condition? Quickly answer that for me, guys. Yes, Dr. Rajat, Dr. Isha, Dr. Rajesh, Dr. Sharina. Yeah, very good. Just make a try of that particular thing. Polyarteritis nodosa associated with which infectious organism? Yes, you can just make a mention of that particular thing very quickly, and the answer I wanted to be familiar with over here happens to be the example of a retrovirus that is present in the Hepatna viridi family. That's going to be hepatitis B. So I help you crack 2 more questions. Hepatitis B belongs to Hepatnaviridae family. It's an example of a DNA virus which is going to be having a reverse transcriptase activity. Remember the fact that's the only example of a hepatitis causing virus which is going to be having a reverse transcriptase activity, and this is going to be unique because normally reverse transcriptase activity is a feature of RNA viruses, but we are talking about a DNA virus having a partial reverse transcriptase activity. For that very reason, as I told you yesterday as well, for the patients who are going to be suffering from hepatitis B infection, you are going to be using a reverse transcriptase inhibitor, and that's an example of a drug that the examiners love to go after time and again, lamivudine. So we are integrating the knowledge of micropath and pharma over here. That's the purpose of having this kind of a discussion. Yeah, right? Okay, so that's going to be lamivudine. That's what I want to be familiar with. Now, given are these 4 options or 5 options, I just expect you to answer correctly. With which of these types of necrosis would you associate the term soap formation? I give you a question in the exam, soap formation. Soap formation, also being given the other important name of saponification. Saponification is a term that you associate with this pattern of necrosis. Yes, guys, very quickly try to answer that. Saponification. These days, the questions in the exam are not going to be commonest one, or they don't expect you to be talking about the examples that you've read in so many times earlier. The questions in the exam are going to be a bit more different. So soap formation, or the question given in the exam is going to be a patient who's going to be having the presence of chalk-like deposits. So now I have given you another important hint. Soap formation, saponification or chalk-like deposits are a finding associated with. Pretty good. Dr. Rajshri, Dr. Niyaz, Dr. Nanda, Dr. Isha, Dr. Rajesh, very good. Everybody talking about the same good answer. That's going to be fat necrosis. Whereas if I'm talking about something which is going to be easy peasy, very cheesy. Easy peasy, very cheesy. Okay, talk about this. Cheesy appearance is what you associate with caseous necrosis, right? So just remember that particular fact from the questions that have been asked you in the exam. And wherever you're going to be asked questions in the exam, so they might as well give you an example of an image-based question over here. Say, for example, they can talk about an example of an organ over here. So they can give you an example of an organ that can be having a presence of a triangular structure that we are going to be giving the name of an infarct. Infarct is typically what you associate with coagulative necrosis, right? Whereas if you're going to be talking about liquefactive necrosis, they will talk about the presence of a image wherein there is a presence of a brain, and there is a classical image that they talk about wherein they're going to be having the presence of a liquefactive necrosis. So liquefactive necrosis also being termed as polyquative necrosis. That's how the questions are going to be put up to you in the exam. So that's about necrosis, about which we need to have an idea. Necrosis characterized by the fact patients are going to be having an irreversible cell injury. There is a presence of an inability to reverse the mitochondrial dysfunction, and there is a damage to the plasma membrane. That's going to be a typical feature that you associate with a patient who's going to be having necrosis, right? The other important example of an irreversible cell injury which the examiners love to ask is going to be apoptosis. Very first question, apoptosis is an example of a condition that's a programmed cell death, and what is written over here, it is an example of a caspase dependent programmed cell death. Caspase dependent programmed cell death. Now I wanted to answer a question because it is a process that is being controlled by P53 and BCL2. I want you to give me an example of a cancer where there is a BCL2 overexpression. That's a very common question. These days they ask you a question, and there's a guy who comes to you with the fact that he's having the presence of lymphadenopathy. On genetic analysis, it was found that this patient was having an overexpression of BCL2. What is the cancer I'm talking about? Which cancer, which is associated with lymph node enlargement, can be having a development of the BCL2 overexpression. BCL2 overexpression is a feature. Hi, Med Psycho, good evening. Hi, Dr. Rajesh. Hi, Bhuvnesh. Alright, BCL2 overexpression is not a feature of CML Bhuvnesh, please, that is what you need to remember. So BCL2 overexpression is a feature of, that's very clear, no? BCL2. So you can remember the answer, B cell lymphoma. When you say things of that sort, it seems to me as if nobody has seen the latest video. So you're all going by the old data. So BCL2 is B cell lymphoma. That means you're talking about a B cell lymphoma, and the kind of B cell lymphoma we are talking about over here, yeah, that's going to be easy because the type of lymphoma which is going to be having in its spelling, L comes 2 times. And the answer would come bang to you like that. No, follicular में L 2 बार आता है यार, L 2 बार आ रहा है, B cell lymphoma. So which type of B cell lymphoma is going to be having BCL2 overexpression? There comes the answer, follicular lymphoma. Those are the kind of memory hacks that I've included in the latest video. So just be familiar with that particular thing. That is what you need to remember over here. Of course, if you're talking about follicular lymphoma, they can obviously ask you a question, the kind of chromosomal translocation with follicular lymphoma, that's going to be 14-18. That's what you need to be aware of over here. So we'll talk about more of those translocations subsequently. I wanted to be familiar with an example of a cancer or a syndrome in which patients are going to be having the presence of P53 gene mutation. So there is an individual in whom multiple families are going to be having. This is especially for the FMG students, Dr. Mushahid. In case you are not going to study anything else, you might as well stay here. In case you have something better to do, please leave this particular session. This is intended for the FMG people. So if you are talking about the P53, and that's going to be an example of a genetic condition, that means a familial condition. We are talking about an example of a syndrome. That kind of a syndrome is what is going to be given the name of Lee-Fraumeni syndrome. Lee-Fraumeni syndrome, Patients are going to be having multiple types of cancers because of the trouble over here. Remember the fact, one-liner questions previously asked in exam. P53 given the name of caretaker of the genome. It's given the name of the guardian of the genome. It's also being given the name of the cell, which is molecular policeman of the cell. So those are the terms that you need to remember over here, right? If I talk about the most characteristic feature of apoptosis, answer that quickly, guys. Answer that quickly. 250 people almost, like 225 people watching this over here. Let's just talk about this. Most characteristic feature, yeah. Most characteristic feature that you're going to be having with regards to apoptosis. What's a characteristic feature? Histological hallmark. Histological hallmark. Most characteristic feature of apoptosis. You need to remember that as chromatin condensation. Chromatin condensation. So chromatin condensation is a hallmark feature for apoptosis and another very frequently asked question in the exam. Be familiar with the fact, in contrast to necrosis, apoptosis can be seen normally as well. That means it can be physiological, and that can be an example of a pathological change. Classical example of physiological apoptosis. I want you to remember about fetal development. I can always use the word embryogenesis in place of fetal development. Very standard example that they put up to you in the exam, right? So you can't afford to go wrong on those questions at least. Please remember the fact, embryogenesis, classical example or best example of physiological apoptosis. Pathological examples, I mean, there are too many. If you're talking about something which is given the name of graft versus host disease, Runt disease, viral hepatitis, if you talk about a condition like retinitis pigmentosa, I've shared all those examples with you. Pathological example of apoptosis, you need to remember about viral hepatitis, and because of viral hepatitis, the microbiology link, you are going to be having the presence of a dense apoptotic body that's given the alternative name of a Councilman body. Councilman body, that's what I wanted to be familiar with, Councilman body. What's an example of a condition where you expect to find this kind of a body? Tory's body. Can somebody just answer that for me? Tory's body is a feature associated with. Can somebody just answer that for me? Tory's body is a feature associated with. Alright, talk about that. Why do we always expect to have the same kind of a set of information? Why can't we have a discussion about new questions? So we need to be familiar with the fact Tory's body is something that you associate in a patient who's going to be suffering from a condition called as yellow fever. Be familiar with that. Yellow fever. Tory's body, yellow fever, that's what you need to remember. Councilman body, of course, viral hepatitis. Name an example of a condition where you expect to have the presence of what is going to be given the name of a Schaumann body. Can I get the answer over here? Schaumann body, very commonly asked in exam. Schaumann body, alright? Very good, very good. Joligar Satvik, Mehbul, Binod Sharina, I'm just so happy you are answering it correctly. Aman Kishanpal, Dr. Ashi Agarwal, yes, Dr. Rajesh, yeah, very good, excellent. A lot of you know about that particular fact. Schaumann body is a finding associated with, yes, Dr. Rajesh, very good. Yes, Dr. Rajat, pretty good, yeah. So if you're talking about something which is going to be given the Schaumann body is going to be a finding in a patient who's going to be suffering from a condition that's given the name of sarcoidosis. Sarcoidosis, yes, Dr. Niaz, the first one to answer that correctly. Very good, Mansi. Always give a try, as I always say that particular thing, right? Yeah, ma'am, this session is maybe useful for INICT, but it's not intended for you people. This is more intended for the people appearing for the FMG June exam. That's the intention. So for INICT, we are having separate sessions. We have made a mention of that particular thing in the thumbnail as well. So in case you have nothing better to do, you might as well stay here. In case you have something to revise, please do that, right? That's what you need to remember here. Now, when you talk about apoptosis, two pathways, and you have a critical role played by mitochondria, powerhouse of the cell playing a critical role, because this kind of powerhouse of the cell is going to be playing a role in intrinsic pathway of apoptosis. So far as the extrinsic pathway is concerned, we have a role played by TNF alpha as well as FASL. I just wanted to remember and revise what is an example of a alternative name given to FASL. So FAS is going to be associated with. Dr. Atul, you don't have to make notes. This is just for your revision. And in any case, the session is going to be staying either in the app or on the channel as well. So might as well slow it down and watch it. Just as of now, just keep on revising. Keep on revising. This is not intended to teach you. I mean, nobody can teach you complete path in 2 hours or something of that sort. That's never the intention. The point is you've already read it, so you keep on revising the facts. So when I'm talking about FASL, that's also going to be given the name of the CD molecule associated with apoptosis. That's going to be CD95. Of course, you are familiar with the role of caspase over here. So different types of caspases that are involved in the intrinsic pathway, you're going to be having the role of caspase 9, extrinsic pathway caspase 8. Overall, you're talking about caspase 10 over here, caspase 3 and 7. That is the thing that we need to be familiar with. There are very important questions put up to you in the exam. So those are high stuffs from the exam that you need to be familiar with, right? I did make a mention of the fact this is caspase dependent program cell death. I'll say that again. Caspase independent program cell death is the name given to necroptosis, right? If I'm going to be talking about an example or a pattern of cell death in which there is going to be a release of interleukin 1 as well as there is going to be a activation of caspase 1. So interleukin 1 as well as the release of caspase 1 is going to be causing fever in the patients. And when you're going to be having fever along with cell death, that is going to be given the name of pyroptosis. Less likely to be asked on the exam, but then you need to be familiar with that fact. Pyroptosis associated with pyrexia. Pyrexia is going to be caused because of secretion of interleukin 1 And the relationship between interleukin 1 and caspase 1 should be very, very clear to you, right? That's what you just need to be familiar with. So those are the typical patterns of irreversible cell injury which are going to be put up to you in the exam. Now, if I'm talking about a next pattern of cell injury, that's going to be given the name of cell cannibalism. Cell cannibalism, typically asked to you as a NEET PGQ bank question. This is going to be other name given to autophagy. Autophagy. Can you just let me know what is an example of a cell-derived pigment? What is an example of a pigment inside the cell which will tell you that there is autophagy which has taken place? Which pigment in the cell is going to be an indicator for autophagy? We are not going to be having nod-like receptors over here, Rajat. Why are we talking about nod-like receptors over here? I didn't get the idea. So nod-like receptors are perhaps something that you talk about when you're making a mention of something like maybe the danger-associated molecular patterns or the PAMPs. But then what I just need to be familiar with over here is cell cannibalism, autophagy. You're going to be having what is given the name of heterophagocytosis, and you're going to be having a deposition of a perinuclear pigment that's given the name of lipofuscin. Autophagy is going to be associated with cell cannibalism. That's a term that I wanted to be familiar with. Have a look at the next important thing, which is going to be adaptation. So we have adaptations like atrophy, hypertrophy, hyperplasia. Recent exam question, when you're going to be having a decrease in the blood supply, decreased blood supply to the brain, that's going to be associated with the development of cerebral atrophy, something that may as well be associated with the development of reduction in the memory of an individual. So that's what you need to be familiar with over here, right? Atrophy. When you're talking about hypertrophy, of course, we are talking about the fact that we are over here referring to the cells, which are typically the example of permanent cells. So I converted from a path question to a physiology question, and I'm talking about permanent cells over here. So permanent cells, the same types of cells which are required to impress a lady. That means we are talking about something like the cardiac cell, we are talking about the brain, and we are talking about the skeletal muscles. Permanent cells, that's what you need to remember. So permanent cells are the ones which are going to be associated with hypertrophy, right? If you're talking about hyperplasia, increase the number of cells. A lot of times hyperplasia is going to be precancerous in nature. It can increase the risk of development of cancer in future, with an important exception. Which type of hyperplasia is not going to be causing a cancer in the future? I hope most of you would be able to answer that very, very comfortably. So boys and girls, elderly males who are going to be having a hyperplasia of the prostate, that's an example of a non-precancerous condition, BHP, benign prostatic hyperplasia. Hi Dr. Bittu, I hope you're doing good. So benign prostatic hyperplasia is what I want to remember. Give me example of 2 drugs which can be given for symptomatic treatment of a patient having benign prostatic hyperplasia. You attended the yesterday pharmacology session by sir. So 2 examples of drugs which are responsible for taking care of a patient having benign prostatic hyperplasia. Yes, the names of drugs. Very good. So we are talking about a 5-alpha reductase inhibitor. The name of the drug happens to be finasteride. And we have another important drug which is going to be acting on the smooth muscles, the alpha-1 receptors. Right? Now, we can't use Hindi, Dr. Bittu. A lot of people do complain about the fact that we are biased towards the North Indians. Nothing of that sort. We are all Indians. That's what matters to me. And let us intermittently, I'll definitely talk about this. So the other important drug that we should be familiar with is a uroselective alpha blocker. That's the name of a drug that's going to be given the name of tamsulosin. So when you talk about tamsulosin, I hope you remember the fact it's going to be associated with improved urinary flow of the patient. Of course, you need to remember about the fact that patients being given tamsulosin should always tell this particular fact to their ophthalmological surgeons, because as and when they're going to be undergoing, let's say, a cataract surgery, they can be suffering from a complication given the name of floppy iris syndrome. Right? That's what you need to remember. Finasteride side effect impotency. We perhaps need to revisit that for the simple reason the dose of finasteride is going to be much less over here, my friend. Right? The other thing I wanted to be familiar with over here is going to be metaplasia, very commonly asked question. So metaplasia, classically 2 types of metaplasia which they love to ask in the exam. This is going to be a NEET PG question recently asked, where they talk about an example of a smoker who was having the development of squamous metaplasia. Smokers having squamous metaplasia is the commonest example of epithelial metaplasia that is to be remembered. And if I'm talking about the esophagus, that's a classical image that most of you should be able to pick up in the exam. Right? Classical image that you should be able to pick up in the exam, wherein you are having the presence of a patient suffering from long-standing gastroesophageal reflux disease. For that very reason, the patients are going to be having, in the lower part of the esophagus, they are going to be having the presence of intestinal columnar metaplasia. And because of the intestinal columnar epithelium replacing the squamous epithelium over here, you are going to be having the presence of these kind of cells which are going to be having that empty kind of an appearance. So those are very good. You know that. Very good. Very good. So a lot of you are talking about that correctly. That's an example of a goblet cell. How do I confirm whether this is a goblet cell or not? For the simple fact that goblet cells are going to be containing the acidic mucin, and in order to pick up the acidic mucin, remember, you're going to be using a stain that's going to be given the name of Alcian blue. So same cells, same picture. If you just have a comparison, same picture, you're going to be having now the bluish appearance of the goblet cells because you are using a stain that's going to be given the name of Alcian blue. So Alcian blue has picked up the acidic mucin, and that is what is going to be showing you the presence of the intestinal columnar metaplasia. Very simple, multiple times asked question, but I still find a lot of people goofing up on that kind of a question in the exam. What if I ask you, suppose this patient is going to be having a development of what is being given the name of Barrett's esophagus, and I tell you that 20 years after suffering from Barrett's esophagus, this patient was unfortunately diagnosed with a cancer of the esophagus. What kind of cancer are we talking about? Can you just make a mention of that in the chat box? Let's just keep on playing that particular thing, mini quiz as well. Yeah, Dr. Praneeth, we are going to be having a limited number of sessions for INICT comprising of the most important subjects. So we had one session that was of pharmacology earlier. We are going to be having more sessions, but we would not be able to complete the course for the INICT considering the constraint of time. However, for the FMG, since we have got a good 45 plus days, we intend to cover almost everything. Yeah, that's going to be adenocarcinoma. Very good. Adenocarcinoma. So that is what you need to be familiar with. Patients are going to be having adenocarcinoma over here over a long period of time if they're going to be suffering from Barrett's esophagus. Barrett's esophagus, right? Now, if somebody was to ask you, suppose you have to treat this kind of a patient. I mean, this patient was having what kind of a disease? He was having reflux esophagitis. What's the example of a drug of choice for reflux esophagitis? Can you just answer that simple, easy pharmacology question for me? All you brilliant boys and girls out there, a simple, easy question. Drug of choice for reflux esophagitis. Yeah, the drug of choice for reflux esophagitis. Yeah, a drug which, if given for a long duration of time, can enhance the risk of development of osteoporosis, has recently been, black box warning being issued because this has been responsible for causing enhanced risk of development of chronic kidney failure as well. A poor sir would not like to give this drug for a long duration because it can be associated with development of osteoporosis as well. So yes, all of you are talking about that correctly. We are talking about a drug given the name of proton pump inhibitors. Right? Very good. Very good. Coming back to the discussion over here. So squamous metaplasia in the lungs of smokers and intestinal columnar metaplasia in the epithelial lining of the esophagus. Those are the examples of epithelial metaplasia. Of course, most of you know the fact. If I were to talk about the connective tissue metaplasia, I would always think in terms of a trauma at the level of the muscles. That's going to be given the name of myositis ossificans. Myositis ossificans. So nothing spectacular that you have to remember over here. Dysplasia is an example of a question that they love to ask in the exam. And the classical example of a tissue that they talk about in the exam for dysplasia happens to be cervical tissue. Cervical tissue having an infection because of a sexually transmitted virus called as human papilloma virus. The human papilloma virus having two types of the subtypes, low risk subtypes as well as the high risk subtypes. And that's going to be a very quick, easy revision for you, which is the most dangerous subtype of the human papilloma virus, which can enhance the risk of development of the problem in the patient. Yeah, of course, doctor. Yes, it can be responsible for causing development of megaloblastic anemia as well. Absolutely. Which is the most dangerous subtype of human papilloma virus? I mean, of course, if you compare the low risk type and the high risk types are more dangerous. But amongst the high risk types, which is the most dangerous? Single best answer that you have to remember. Remember the age when you are most dangerous. So almost everybody, north and south, Hindi and the other filmmakers have exploited it. So I always talk about 16 साल वाली उम्र जो होती है. Exactly, HPV 16, that's the most dangerous. Don't answer it as 18, guys. You turn adult when you become 18. It's the pre-adult, which are going to be the most troublesome. So it's a 16, HPV 16, which is going to be more dangerous. Why is it going to be more dangerous? For the simple fact, you're going to be having secretion of E6 and E7 because of the human papilloma virus. That is going to be causing the trouble over here. So old question, E6 causing underactivity of something given the name of P53, E7 causing underactivity of RB. That's the reason why they're going to be causing the trouble in the patients. If you know that microbiology point, you can just revise it. If you don't know it, don't worry. Make sure that you don't make a mistake in the exam. That's more important. Giving me a wrong answer over here in the live session doesn't make a difference to either your health or my health. But let us not get it wrong in the exam, because nowadays in the exam they are not asking you direct questions like that. So they'll talk about a lady, let's say, who was indulging in sexual activity, and now she was having some kind of a pre-screening program wherein she had given a tissue, and this tissue was having the presence of certain types of nuclear polymorphism, cellular polymorphism, loss of polarity, stuff like that, and then she was diagnosed with something like cervical dysplasia. So what's the organism? What is going to be the pathophysiological reason for the findings that we see in her? Those are the kind of questions that we need to be familiar with. So that's about adaptation. And of course, I mean, you know the fact, adaptation is going to be an example of a reversible change if you're going to be removing the stress factor. So that's a very, very high image. That's a must-know image that you need to remember for exams. No need for me to explain that 4 times asked in the exam. Talking about the next important thing, very, very ultra lovely pigment of the examiners, that's going to be calcification. You just need to remember 2 patterns of calcification, dystrophic and metastatic. In dystrophic calcification, remember the fact you're going to be having alphabet D for dystrophic. So you're going to be having the involvement of either dead cells or you're going to be having the involvement of degenerated tissues. Degenerated tissues. Remember the fact, in case of dystrophic calcification, you have the presence of normocalcemia. Serum calcium remains normal. It is not going to be elevated. Yeah. Dr. Sahil, this is going to be a revision. Nobody can take the guarantee of the fact whether this is going to be enough or not. We are not the paper setters, but what we can just help you is having a quick revision. I mean, instead of watching down all those shorts and non-academic stuff, I think it is still going to be expected from you to have a revision of all the points that we are having a discussion of over here. Metastatic, that's going to be causing involvement of the living tissues, and why living tissues are affected, because my patients are going to be having elevated calcium levels, so he's going to be having hypercalcemia. So whenever a question talks about normocalcemia and degenerated cells, dystrophic, living tissues, hypercalcemia, think in terms of metastatic calcification. Classical examples would be a guy who is coming to your clinic, especially a medicine clinic. This guy was having the presence of a difficulty in breathing. On examination, it was found that he was having some kind of a valvular trouble, and unfortunately the patient did not survive. On autopsy, this guy was having the presence of a valve which was having an appearance like this, in which the valve was having the presence of calcium deposition over here. Now when you have a damaged valve having a calcium deposition over here, that's going to be associated with damaged valve. When you write the word damage, whether it is degenerated or whether it is dead cell, so damaged valve is going to be having the presence of dystrophic calcification. That is what I want you to be familiar with, right? The other thing that we need to be familiar with over here is, sometimes if you're looking at calcium in the routine staining, I mean the term hematoxylin eosin staining, the calcium is going to be having a bluish appearance. So that's going to be given the name of a basophilic appearance of calcium. Basophilic appearance of calcium. Now these are the 4 most commonly asked options given in exam time and again. Try to answer it yourself. What is the specific type of calcification which comes to your mind if I'm talking about a patient who is suffering from chronic renal failure? So chronic renal failure or chronic kidney disease, what's the type of calcification which comes to your mind? Alright, the type of calcification with chronic renal failure, that's an example of a metastatic calcification. Remember the fact, CRF is going to be the most common reason for the development of secondary hyperparathyroidism because of retention of phosphate. I have explained you the concept of nephrocalcinosis in the video. If you watched it, good. If you haven't watched it, just remember the fact, patients are going to be having a development of metastatic calcification. Parathyroid tumor. Parathyroid tumor is going to be associated with metastatic calcification. PTH increases calcium, so metastatic again. Multiple myeloma, there is a bony destruction, osteolytic lesions present, so that's an example of metastatic calcification. These have all been asked in the exams. What you were given in the exam, the last exam, the question was, which of the following is not going to cause metastatic calcification? So the answer over here there was atherosclerosis. So first 3 conditions, metastatic calcification, last condition atherosclerosis. You have a degeneration of the cells, so this is going to be associated with dystrophic calcification. I hope you remember that particular fact. So examples of dystrophic and metastatic calcification should be absolutely clear to you. Just answer for me in the chat box, guys, what is the commonest organ affected because of the calcium deposition? Commonest organ affected because of calcium deposition. That is what I want you to be familiar with, right? Commonest organ affected because of calcium deposition. Commonest organ affected because of calcium deposition. I just want you to answer that. Yeah, so calcium deposition is typically going to take place at any particular place where you're going to be having the presence of an alkaline environment. Alkaline environment, so that's going to be lungs. That's going to be lungs. Yeah. All right. So that is what I just wanted to be familiar with, guys. We're going to be having a situation wherein we are going to be talking about more examples of the pigments which are going to be seen, and one of the ways by which calcium gets deposited, which your examiners love to ask you, is going to be something like a semoma body. So you got a question in 2020 exam, there was another question in the 2021 exam, and then recent exam also one of the questions that made a mention of the fact, and I just want you to remember those 7 conditions where you're going to be having a structure called as semoma body. The moment you think in terms of semoma body, what should come to your mind? M stands for a tumor. I'm just making a quick revision of the fact. This is going to be meningioma. That's an example of a brain tumor. So that was a question asked to you in the exam. What is the clinical history of a patient having meningioma? Instead of giving you semoma body as a question, what the examiners will tell you that there is a middle-aged lady, and let us say this lady was having the development of cranial nerve palsy, or she was having epileptic fits. So she was having convulsions, or she was having cranial nerve palsy, or she was having features of increased intracranial tension, and there was an example of a growth which was extending towards the dura as well. So the dural Taine sign, if you can remember radiology, and the biopsy was taken from her tumor, and this biopsy of the brain tissue was having the presence of semoma body. So we are talking about something called as a meningioma. Alright, so I mean, but the point is that they may not be giving a direct question in the exam. They will not tell you it is a meningioma, they'll give you clinical history. So meningioma is an example of a tumor which is going to be seen in case of a female. That's going to be associated with cranial nerve palsy or features of increased intracranial tension or the presence of a dural Taine sign. and on the biopsy you are having a picture like this, so that is going to be a meningioma. Second example of a tumor that we need to have an idea, which is going to be having a semoma body, is going to be a mesothelioma. So when you talk about a mesothelioma, this is going to be associated with exposure to a dangerous chemical that is going to be given the name of asbestos. So there's a guy who's going to be working, let's say, in a car making factory, because of the fact that he's going to be involved in some kind of an insulation industry, and because asbestos is being used for fireproofing material and waterproofing, I have told you so many times earlier, or shipbuilding factory. And then this guy was having the presence of a tumor in the thoracic cavity, which is going to be given the name of a mesothelioma. And this mesothelioma again is going to be having the presence of the structure which is going to be having calcium deposition, so it could be having the presence of a semoma body. O obviously stands for the fact patients are having an ovarian tumor. The kind of tumor we are talking about over here happens to be what is given the name of a serous cystadenoma. Very, very commonly asked question, and the gynae people would love to go after this kind of a question. Serous cystadenoma is a tumor that we need to be familiar with over here. S what stands for the salivary gland tumor, less likely to be asked in the exam. T is a very favorite of your examiners. It's a papillary thyroid cancer. It's a PTC, the papillary thyroid cancer, which is going to be responsible for causing the trouble in the patients. Papillary thyroid cancer responsible for causing the trouble in the patients. That's what we need to have an idea. I hope most of you can just remember and revise that, right? Yeah. Seen after 25 years means I didn't get you, doc. I mean, okay. So we are talking about P and G. P and G are typically given to you as PG exam questions, but then if you're familiar with this, very good. P stands for a tumor which is going to be associated with female having complaint. She's going to be having reduced fertility and there is going to be milk coming out of her breast tissue, so that's going to be prolactinoma. And G would stand for the fact the patients at times are going to be having a tumor that's going to be given the name of glucagonoma. In fact, some of the books do make a mention of the fact that whenever the patients are going to be having a tumor that's going to be given in a somatostatinoma, even that could be having the presence of a semoma body. So the point is that just be familiar with that kind of a history that they typically would love to ask in the exam. So the trend these days is they'll not give you a question directly on meningioma or on mesothelioma or prolactinoma. So they'll talk about a lady who's having this kind of a complaint, milk ejection from her breast tissue, their milk is oozing out and then she's having reduced fertility, so hypogonadism features are seen. Or for example, a patient is going to be having the presence of an ovarian enlargement and then she was having a weight loss, so maybe she's thinking in terms of something like a serous cystadenoma. Or the question can talk about a patient having a history of radiation exposure developing a thyroid cancer. I mean, papillary thyroid cancer, you remember, it's associated with, very strongly associated with a history of radiation exposure, especially in young people. So young guy having a radiation exposure maybe near the atomic bombing, Hiroshima, Nagasaki, and then this guy was having the presence of a papillary structure over here, so that's going to be having the presence of a semoma body. So clinical histories and the concepts are what are going to be very, very important. That is what you need to remember over here. Hi Dr. Madineni sir, very good evening. Thank you so much for joining in for the session. That's what we need to remember over here. So I hope the concept is clear. Having said that, now that's going to be easy. Lipofuscin, an example of a perinuclear yellow-brown color pigment. Name the example of a structure inside the cell, the organelle inside the cell where lipofuscin is going to be having a deposition. I say it is perinuclear, but perinuclear, which is the organelle in which lipofuscin is going to be having an accumulation. Hi, just answer that for me. I mean, now that you are already aware of the fact, so they'll talk about an elderly male who was found, dead in his house, and the neighbors called the police, and then the body was sent for the post-mortem and on the autopsy. They were having an examination of the cardiac tissue, where the cardiac tissue was showing you presence of a yellow-brown pigment which was present in the perinuclear location. So what is an organelle? Which is an organelle which is going to be having this kind of a lipofuscin pigment? Can you just let me know? No, it's not going to be seen in the it's not going to be seen. Organelle means within the cell, guys, within the cell. So I'm already saying it as an example of a thing that is present in the cardiac tissues. But in the cardiac tissue, I mean, where do you have lipofuscin deposition taking place? Is it in the mitochondria? No, it's not in the mitochondria. It's going to be an example of an intralysosomal. Remember the fact, lysosomal. It's going to be an example of an intralysosomal pigment deposition. Guys, you can't afford to go wrong on questions which have already been asked in the exam. I've shared this information with you earlier. I mean, if you don't answer it correctly, that means you haven't watched the videos. Please don't goof up on the fact that somebody claims that he, she or it, they are going to be teaching you something, that everything is going to be coming from there. The concepts are important. So I give you clinical history and I want you to remember the fact that this is going to be lipofuscin. So lipo is going to be derived from lipids. So you're associated with the terms like, yes, most of you are now talking about that correctly. So we are talking about something called as by the name of lipid peroxidation. We're talking about something called as free radical injury. We're talking about the wear and tear pigment. We call it by the name of the telltale sign of free radical injury. That's what I just wanted to be familiar with over here, right? So that's exactly what you need to be having an idea. Now, apart from aging, the other important example of a condition where lipofuscin deposition can take place can be protein energy malnutrition. You can also have it in a patient who's going to be suffering from a cancer. So when you're talking about cancer cachexia, when you're talking about protein allergy malnutrition, that's other example of conditions where you're going to be having the deposition of lipofuscin. Please don't make a mistake on that particular thing in the exams. That's a very, very high stuff. Now, if I were to ask you what is the most common reason for the aging of an individual, what explains the aging of an individual? What explains the aging in case of an individual? Can you correlate aging of an individual with the presence of free radicals? Yes. So there is going to be free radical injury, which can be responsible for causing aging in case of an individual. Right? We also maybe are familiar with the fact how can we increase age of an individual now that you already know about that particular fact. Hi Gobind sir, good evening. Thank you so much for joining in and encouragement. Yeah, so we are going to be talking about something that is going to be given the name of, yes, calorie restriction. Hi Dr. Akhil. Okay, right? So that's what you need to be familiar with, guys. So just be familiar with the fact the lesser you are going to eat, the better it is for your longevity. Calorie restriction. Decrease the calorie intake by 30%. That is not going to be associated with development of malnutrition. At the same time, it's going to be associated with increase in the longevity of an individual. That's what we need to be familiar with. Yeah, Dr. JB, you don't need to worry if you have taken the plan. I mean, we're going to be conducting live sessions, much more detailed sessions for you guys. I mean, this is just going to be Dr. Akhil, instead of wine consumption, I would rather request you to be focusing on calorie restriction. That's the first one. And the most optimal answer, of course, you can be going in for something like wine consumption and the concept of surge veins. But I mean, practically speaking, nobody is going to be allowing you to have a couple of drinks of wine just to increase your age, because then you get sloshed off, right? Having said that, talking about the next one, hemosiderin. Now, instead of giving you directly hemosiderin question, the blue color, now that most of you are already familiar with, this is going to be Prussian blue, and the kind of reaction that we are making a mention of over here, that's going to be in the name of Pearl reaction, Prussian blue. So hemosiderin, iron derived pigment, that's what we need to have an idea. And the question will talk about the fact that this guy is going to be having a, let's say this guy was having some kind of a blood dyscrasia, he was having some kind of a blood disorder, because of which he was having he was receiving multiple blood transfusions, which is going to be associated with the development of iron overload. What's the condition I'm talking about? Guys? What's the condition I'm talking about? Multiple blood transfusions causing iron overload in the patient. Yeah, we are talking about an example of a condition that's going to be given the name of, yes, thalassemia major, thal major patients being given blood transfusions time and again, and now these guys are going to be having a development of iron overload, and that iron overload is going to be causing the death of the patient. The extra amount of iron being detected with the help of Prussian blue, so that's going to be associated with hemosiderin deposition, right? And that's an example of an easy question. I mean, now that everybody talks about the same thing over here, so calcium can be detected. It is going to be having a reddish color when you're going to be using alizarin red. Calcium is going to be having a black color. So most of the people would obviously talk about the fact वो कौन सा stain था जिसमें calcium काला लगता है, and that's going to be black. That's going to be von Cosa. Calcium is going to be appearing a red with the help of an application of a stain called by the name of alizarin red. Of course, you can detect a small amount of calcium when you're talking about alizarin red. So जरा सा भी calcium देखना हो, red color का देखना हो, then you're going to be using alizarin red, and the black one is going to be von Cosa. Of course, I can be using von Cosa as well as other stains as well, but these are the most common things that they'll have to ask in the exam. So be familiar with the most important ones. Lipofuscin is a pigment, calcium is a pigment to go in for, and you need to be familiar with hemosiderin as well as alizarin and von Cosa, right? That's about what we need to be having an idea so far as the discussion of cell injury is concerned in the quickest possible time. Having then a discussion about something which is going to be given the name of, inflammation. So inflammation having two components. You're going to be having a vascular component of inflammation and a cellular component of inflammation. Vascular component, easy for you to remember. First you have vasoconstriction, then vasodilation, then increased permeability and stasis. Increased permeability being highlighted for the fact this is the most characteristic feature. This is the most characteristic or the hallmark feature associated with acute inflammation. Obviously, I would expect most of you to remember the reason for the increase in permeability. Can you just quickly type that in the chat box? Commonest mechanism for increase in the vascular permeability. Commonest mechanism for increase in the vascular permeability happens to be endothelial cell contraction. Right, so that's essential for you to be familiar with. If I'm talking about cellular changes, you divide them into two categories. Changes that are taking place inside the cells, they're going to be given the name of intravascular changes, taking place inside the blood vessels, intravascular changes, and then you have changes taking place outside the vessels, that's given the name of extravascular changes. So with respect to, for chronic, you're going to be having the hallmark feature as tissue damage or tissue destruction, friend. In case of intravascular, that was an 8 PG question. They asked you to arrange the sequence of the cellular changes. So you're going to be having MRAD, Mr. AD is what I just wanted to be familiar with over here. So margination, you're going to be having rolling, you're going to be having adhesion, and you're going to be having diapedesis. Very quickly, if you can just recall for me, if I'm talking about rolling, that is going to be taking place because of selectance. What is the molecule on which adhesion depends? Can somebody just revise that for me in the chat box? Yeah, adhesion depends upon which particular molecule. Can you just revise that for me? So adhesion is going to be dependent upon molecules which are going to be given the name of integrants. Integrants, right? If I'm making a mention of something like diapedesis is also being given the name of transmigration. And if I'm talking about transmigration, that is going to be dependent upon a molecule that's going to be given a name of CD31. Transmigration, CD31. That's what you need to remember. So far as the extravascular changes are concerned, you're going to be having the movement of the white blood cells towards the bacteria. That's going to be chemotaxis. Then you're going to be having the coating of the bacteria on all sides by molecules given the name of opsonization. And finally, we're going to be having phagocytosis. Just revise for me example of an external chemotactic molecule. External chemotactic molecule, very quickly, if you can just answer for me. Very quickly answer for me example of an external chemotactic molecule. So external chemotactic molecule that we need to have an idea is going to be bacteria, bacterial products. Which complement protein is going to be acting as a chemotactic factor, that is C5a. Which leukotriene is going to be causing chemotaxis, that's going to be leukotriene B4. And of course I can be talking about something which is going to be given the name of interleukinate. So those are standard questions that they put up to you in the exam. Revise for me the example of the most important molecule required for opsonization. Very quickly in the chat box. Yes guys, most important opsonin molecule that we need to have an idea. These are easy questions. I mean, don't goof up on those questions. I mean, you must pat your back if you're able to answer those questions correctly, but then you should be able to pull your hair as well if you're not able to recall them. The purpose is, however, that you should be able to recall. And the most important molecule required for opsonization is an antibody, that's going to be IgG. Of course, we are going to be having the role played by C3b as well. And we are going to be having the role played by molecules like fibrinogen. We are going to be having the role played by C-reactive protein as well, right? Phagocytosis. Phagocytosis is going to be an example of a process in which you're going to be engulfing the bacteria using actin polymerization. Subsequently, you're going to be killing them. And the killing is going to be taking place because of either an oxygen-dependent mechanism or the oxygen-independent mechanism. Right. Hi, Dr. Tubulina. Okay. That doesn't make a difference, but then quickly just go through this. This is almost a kind of, I would say, a very therapeutic kind of a session wherein you just sit back, relax, and just keep on revising the points. I mean, that's the kind of stuff that is required or expected from you. So that was the information I was sharing with you. All that information written over here as well. Bacterial product, external chemotactic molecule, rest of them are endogenous. Opsonization required for preferential killing. IgG is what is very, very special. Phagocytosis dependent upon the actin as well as the activity of a protein that's given the name of list protein, right? And when we're talking about the killing, you are going to be having oxygen dependent mechanism. You require two enzymes over here which are given the name of NADPH oxidase and myeloperoxidase. Oxygen independent killing, that is going to be dependent upon several types of molecules including major basic protein as well as a protein that's given the name of defensins. I believe that's very, very clear to you, right? Now, having said that, be familiar with the fact that what is an example of a condition if a patient is going to be having list protein defect. Can you just let me know, guys? And that's a hint for you. Identify the condition I'm making a mention of if I show you this kind of a picture. Pretty good. Just make a try. Patients are going to be having a list protein defect, and therefore the patients are going to be having increased risk for development of infections. The guy is going to be having albinism. On the peripheral blood smear, you have neutrophils which are going to be containing giant granules, and the patients are going to be having the development of enhanced risk of platelet bleeding. This is going to be a development of very good Shidiak-Higashi syndrome. Shidiak-Higashi syndrome. So Shidiak-Higashi syndrome, the patients are going to be at high risk of development of multiple infections. They are having a bleeding tendency as well. Patients are having albinism as well. And the characteristic feature, you have those big granules inside the neutrophils, which is abnormal. This is abnormal actually. So big granules inside the cells, that's what you need to be familiar with so far as Shidiak-Higashi syndrome is concerned. I want you to recall and revise for me the name of a condition which is going to be seen if there is going to be NADPH oxidase defect. What's the condition we are referring to over here? NADPH oxidase defect. Almost 180 to 200 people watching over here. So please recall that correctly for me. Example of a condition where you're going to be having NADPH oxidase defect. That condition is going to be given the name of chronic granulomatous disease. Chronic granulomatous disease. Now listen to my question carefully, because if I ask you what is the most definitive treatment of a patient suffering from chronic granulomatous disease? Definitive treatment of a patient suffering from chronic granulomatous disease. Answer that correctly. Try to answer that correctly. I mean, a lot of you are perhaps on auto mode when you answer it, because we expect certain things to be asked to us in exactly the same way as they have been taught. But my question is, what's the definitive treatment of a patient suffering from chronic granulomatous disease? Can somebody just answer that for me? Okay, quickly guys. right? So definitive treatment. Now I'm not talking about over here the administration of something called as interferon gamma. That's not going to be the definitive treatment, not the antibiotics. Definitive treatment means that you're going to be treating the condition of the patient. Forget splenectomy, Dr. Vishal, please. Factor 10, Dr. Devya Kumari, I don't know. Maybe some of you may be watching simultaneously multiple videos. We cannot be talking about splenectomy or factor X over here. But what I wanted to be familiar with over here is the patient's definitive treatment is going to be something called as bone marrow transplantation, guys. You are having a genetic defect. You cannot correct a genetic defect just like that. So you better do a bone marrow transplantation for these patients. Definitive treatment is bone marrow transplantation. I mean, symptomatic, you are going to be giving drugs. Symptomatic, you're going to be giving antibiotics. Symptomatic, you're going to be giving interferon gamma. But remember, bone marrow transplant, definitive treatment. Major basic protein. One keyword, eosinophils. If you remember it, half of the trouble is solved. Eosinophils. So eosinophils are going to be containing major basic protein. You're going to be answering for me. I mean, no surgery, no Dr. Med Psycho. You don't do surgery for these patients. Remember the eosinophil. If you're going to be talking about eosinophil, which is an example of an interleukin which comes to my mind. That's an easy question. That's a fairly easy question. Eosinophils are going to be attracted by which particular type of interleukin? Eosinophils are attracted by which particular type of interleukin? That's an easy question that you need to be familiar with. Yeah, eosinophil, alphabet E, fifth alphabet, that's the answer. Interleukin 5. Interleukin 5. Right? But if my question is, which is an example of interleukin which is going to be associated with IgE antibody secretion? Now, be familiar with the question. Yeah, so for this one, you're going to be answering it as interleukin 4. That's a very common area of confusion. I just wanted to be familiar with. So interleukin 4 primarily associated with IgE antibody secretion, whereas interleukin 5 is going to be contributing to increase in the number of eosinophils, and that explains the parasitic infections, allergic conditions having an eosinophilia. That's what we have a discussion about earlier as well. So that's going to be an easy question, but then that's what is going to be asked to you in the exam as well. Talking about the example of chemical mediators, easy questions, and that's the exact table that they have asked you in the exams in the last 5 years. I mean, cellular mediators, histamine is going to be pretty important, and you're going to be having serotonin playing an important role. Now, I wanted to be familiar with the fact that histamine, you're going to be having multiple receptors, H1 receptor and H2 receptor. Which of these receptors are you going to be associating with inflammation? H1 or H2? Answer that very quickly, guys. H1 or H2 associated with inflammation. So it is a H1 receptor associated with inflammation. That's what I wanted to remember. H2 receptor is also asked you in the exam because Govind sir taught it. It is going to be involved in gastric acid secretion. So you have H2 blockers, ranitidine, famotidine given for taking care of gastritis. Remember that. Having said that, cellular freshly formed mediators. Very easy biochem question. Nitric oxide. What's the amino acid source? What's the amino acid source? Which amino acid is responsible for giving me nitric oxide? Which amino acid gives me nitric oxide? The answer is pretty easy. That's going to be arginine. Arginine. Nitric oxide, does it cause fever? The answer is no. Nitric oxide says no, I don't cause fever. No, I don't cause fever. 3 times asked question for your exam. So you are going to be having fever development in a patient having infections or inflammation, particularly in association with the secretion of interleukin 1 or TNF alpha or prostaglandins or COX enzyme overactivity, but nitric oxide does not cause fever in case of an individual. Easy one. Cytokines. Interleukin 1, interleukin 6 responsible for causing systemic effects of inflammation. Why did I make a mention of interleukin 10 and TGF beta? They are anti-inflammatory cytokines. Anti-inflammatory cytokines. Revise for me. Example of cytokines having a dual action. Revise for me. Example of cytokines having a dual action. That means in some conditions they increase inflammation, in other conditions decrease inflammation. I answered that quickly, guys. Don't look at your notes. No cheating. You're all good people, wonderful boys and girls. Cytokines having a dual action. Cytokines having a dual action. They make us increase inflammation in some conditions. They are responsible for having anti-inflammatory action in other conditions. What are the cytokines we are referring to? Please talk about that. So all you cricketers, all you Virat Kohli and MSD fans, remember the fact we are hitting the balls 4 and 6s. Interleukin 4, interleukin 6 are going to be having a dual action, right? That's exactly what we need to be familiar with over here. Talking about arachidonic acid metabolites, they're going to be prostaglandins, thromboxane A2 and leukotrienes. Now give me an example of an arachidonic acid metabolite which decreases inflammation. That's an easy question. You watch the video, you know the answer. Watch the video, know the answer. Arachidonic acid metabolite causing decrease in inflammation. Yes, very good. Some of you know it. Pat your backs. Yes, very good. That is lipoxins. If you're talking about prostaglandins, the most specific prostaglandin causing fever and pain, prostaglandin E2. Thromboxane A2 causes platelet aggregation. Leukotrienes responsible for causing bronchospasm. Leukotrienes cause bronchospasm, typically in a patient suffering from bronchial asthma. So we know that particular fact. Plasma chemical mediators, kinin system, bradykinin, very commonly asked question in the exam. Kinin system activation takes place because of factor number 12. Factor number 12 also causes activation of coagulation cascade. Factor number 12 also activates fibrinolytic pathway. So all these are going to be interlinked. That's what I want you to be familiar with. If I'm talking about something called as coagulation cascade, I want you to be familiar with the fact. Coagulation cascade. Coagulation is dependent upon which vitamin? That's going to be vitamin K. So when you write coagulation, in fact phonetically coagulation, vitamin K. Which vitamins are not present in the breast milk? So we'll take a cue from what Vivek Jain sir has taught you beautifully in PSM. I mean, one of the few subjects in which you have the complete lecture. So finish your pharmacology very quickly, finish your PSM, absolutely high, amazing information that you're having in the exams. Which vitamins are not present in sufficient amounts in the breast milk? My question is, which vitamins are not present in sufficient amount in the breast milk? Very good, very good. Which vitamins are not present in sufficient amount in the breast milk? And the answer is simply, sir, I don't know. I don't know. Very good. And that is what you need to remember. So when you say I don't know, the answer is vitamin D and vitamin K. I don't know, but the fact is you know the answer. That's a very interesting and a beautiful way to remember the fact. Vitamin D and vitamin K are minimally present. They are present in less quantity in the breast milk, and therefore clinically you relate that particular fact with a pediatrics question that a newborn baby is being given a vitamin K injection right at the time of birth. Right? So vitamin K dependent factors are going to be produced in them, like 2, 7, 9 and 10. Vitamin K dependent factors 2, 7, 9 and 10. There comes a pharmacology link. We have a drug which decreases the activity of vitamin. Yes, Dr. Tajamul, now you know it, right? So whether you write it as DK, you write it as KD, doesn't make a difference. Mark that correctly in the exam, right? When you're talking about vitamin K activity is interfered with an example of a drug that was a NEET PG question, warfarin. So the question asked in the exam is, there is a guy coming in the hospital with a feature of hypercoagulation. When you're talking about hypercoagulation, are we going to vitamin A present in a relatively smaller amount, I would say, guys. So when I'm talking about vitamin K activity is going to be interfered with a drug that's going to be given the name of warfarin. Warfarin is going to decrease the concentration of factors 2, 7, 9 and 10. That was a NEET PG question. Congratulations. Preparing for the FMGE exam, but you cracked the NEET PG question. When you're talking about the coagulation cascade, you are going to be having the two pathways, intrinsic pathway and extrinsic pathway. Questions in the exams can be really easy. In which of these pathways you are going to be having a role of factor 7? Factor 7. Factor 7. Factor 7, interesting physiology fact. It's having the shortest half-life. Factor 7 having the shortest half-life. So it's going to be involved in which pathway of the coagulation cascade, intrinsic or extrinsic, guys? Please answer that quickly. That's an easy one. You are brilliant people watching this. Yeah, for most of you, you know the answer. Factor 7 is involved in which pathway? That's going to be involved in the extrinsic pathway. Extrinsic pathway being monitored with the help of a parameter that's given the name of PT. Intrinsic pathway, longer pathway, monitored with the help of a parameter given the name of APTT. I want to check for the prothrombin time or the APTT. What is an example of a syringe in which I should be taking a sample? Should I be taking a sample in a glass syringe? And the answer is no. Glass syringe is going to be negatively charged. So I don't want to activate the pathway. So what is a syringe which I would be using? Very good. The one that I'm using in the ward. What syringe am I using in the ward? It's a plastic syringe. So plastic syringe is what is going to be useful over here. Right? Intrinsic, extrinsic pathway monitoring done with the help of plastic syringes. You are going to be taking the sample. And this has to be calculated very early. So when you talk about PT and APTT, there are two things that we are looking at. Remember, 2. So the test has to be done within 2 hours. I mean, the results are going to be altered, right? That's what you need to be familiar with. And then when you're talking about the complement system, a lot of information, easy information. C5A, what is the role? Chemotaxis. C3B, what is the role? Sir, opsonization. MAC formation, what's the function? C5B-9 complex. Killing or punching hole in the organism. That's easy for you to remember. So you need to be familiar with that particular fact. Recent exam question. If I'm going to be having a deficiency of complement proteins, my patient can be having a development of increased risk of infections. Sometimes this can be associated with a troublesome condition in the patient. What's the condition which comes to your mind? If my patient is going to be having a problem in the regulatory function of CD55, CD59, answer that. Yes, guys. My patient is having a problem in the regulatory complement protein activity. So there is a problem with CD55 and CD59. What's the disease which my patient is going to be having? Please answer that correctly. Yeah, please answer that correctly. And the name of the disorder happens to be paroxysmal nocturnal hemoglobinuria. Paroxysmal nocturnal hemoglobinuria. Your examiners love to ask you about this disorder. Thankfully a rare disorder, but examiners love to ask you. So common questions. So that is what is going to take care of the chemical mediators. Easy but important. Very, very high stuff that you need to remember and revise for exam. Yes, Dr. Rajshri. Yes, Dr. Priya Ranjani. Yes, very good. Chronic inflammation characterized by tissue damage as a hallmark feature. It can be granulomatous or non-granulomatous inflammation. Of course, any question exam talking about a granulomatous inflammation will never be complete if they don't ask you a question on tuberculosis. I mean, in the recent exam also, so many questions that they gave you in the exam which were based upon a particular condition. So examiners just went after the sexually transmitted diseases, they went after infections. Similarly, tuberculosis, classical example of a chronic granulomatous inflammation. And the finding of tuberculosis, as we understand, is going to be a caseating granuloma. You can be having granulomatous inflammation with foreign body, in sarcoidosis, in Crohn's disease, in definitely a lot of vasculitis disorders and cat scratch disease. Remember the name of the granuloma and cat scratch disease, last to last exam question, what is going to be? No, Dr. Devya, if you have something better to do, better you focus on the INI exam. But this question discussion is going to be fairly basic. However, it is important. In case you find it something that you are not aware of, you can keep on watching the discussion. In case you feel it is too basic, you might as well do something better, right? Cat scratch disease, what's the shape of the granuloma? What's the shape of the granuloma? Yeah. A beautiful star, a beautiful star. That's exactly what they put up to you in the exam. Stellate granuloma, stellate granuloma, stellate granuloma, cat scratch disease. Stellate granuloma, cat scratch disease, right? That was an easy one. So by this point of time, I expect most of you to be familiarizing yourself with the donut granuloma, of Q fever, Dirk granuloma, malaria, cat scratch disease, stellate granuloma. Those terms are familiar to you. Nonetheless, I would still make a mention of the fact that patients can be having presence of this kind of a cell. That's what they love to ask you as a question in the exam. Cell in which you're going to be having multiple nuclei present in the periphery. That's given the name of a cell which is going to be given the name of Langhans cell. And this Langhans cell is going to be associated with what? It's associated in a patient suffering from tuberculosis infection. Foreign body giant cell. Haphazard arrangement of the nuclei. Child is going to be having presence of fever and complex spot. Fever, complex spot, measles. Fever, complex spot, measles. And you're going to be talking about, that's often asked question. I mean, in the recent exam also, in the January exam also, you got a question on this. Can you believe it? Such an easy question in which you're talking about an example of a giant cell, two nuclei, mirror image of each other, prominent nucleoli being present. That's going to be given the name of a Reed-Sternberg cell. Hi Abhishek, if you're thinking in terms of a, if you're thinking in terms of a Langhans cell, no, we are talking about Langhans giant cell. So Langhans giant cell is what you associate with. Dhruv, we are not talking about Langerhans cell, my friend. That's exactly the mistake which is supposed to be avoided. If you're talking about the cell over here, this is going to be an example of a Reed-Sternberg cell. However, this cell is going to be having an owl eye appearance. If I'm talking about owl eye inclusions, that is going to be seen in a patient suffering from CMV infection. Another question. So just read about that particular fact in the exam very carefully. These are not to be missed questions, they're easy questions. That is what you need to be familiar with. Of course, if I were to talk about something with the concept of wound healing, does a wound ever attain 100% of the strength? Never ever. In the first week, it is going to be attaining how much of strength? 10%. At the end of around 3 months, it is going to be achieving what kind of a strength? 70%. 100% strength? Never ever. That's what you need to be aware of so far as the concept of wound healing is concerned, right? So easy questions that I put up to you in the exam. Now, if I were to ask you this kind of a question, suppose this is the patient who's coming to me with the presence of a lymph node enlargement, whether it is axillary, whether it is going to be cervical, and I find the lymph node biopsy showing me this kind of a picture. And I ask you a question, my friend, what is the most common subtype of this kind of a tumor that is seen in our country? What's the answer, guys? What's the answer? Most common subtype of this kind of a tumor that is seen in our country. So India is going to be containing, right? India is going to be containing India is going to be having which particular subtype of Hodgkin's? That's going to be the commonest one. Yeah, very good. Which type of Hodgkin's is commonest in our country? Pretty good. Okay, Hodgkin's is what you are answering. Positive vibe, medico. Alright, I agree. Then, what subtype of Hodgkin's are we having in our country? No, it's not the nodular sclerosis, my friend. It is going to be the classical one, but the example is going to be, alright, it's going to be the mixed cellularity. Yes, Dhruv. Yes, Dr. Tajamul, you're absolutely right. Right. Hi, Dr. Tripathi. Good to see you as well, my friend. Right. So that is what you need to have an idea. Then talking about immunity. Immunity is dependent upon how exactly are you going to be fighting the infections in our body, and that is going to be done with the help of special types of cells. Those cells can include the antigen presenting cells, most important of which happens to be the dendritic cells, right? So the dendritic cell which is going to be playing a very critical role happens to be the Yes, that cell is given the name of a Langerhans cell, right? We also having B cells and macrophages playing a very, very important role or a critical role. Now, when we are talking about the MHCs, these are the molecule present on the surface of the APCs. I mean, you know that simple fact. That's an example of the antigen attaching itself with the MHC molecule, and the MHC molecule is present on the surface of APC. And this kind of an APC, please remember, is going to be associated with attachment of the antigen. Why that is important? Because this antigen is now going to be going to the different areas, the different types of cells, and that is what is going to be responsible for activation of different cells in the body. So which are the cells I am referring to? The cells I am referring to over here, MHC1. MHC1 is going to be associated with antigen causing activation of the CD8 T cells, MHC2 causing activation of the CD4 T cells. That is what we need to have an idea. So we already know about the rule of 8, and that's easy for most of you to pick up over here. Now, what are the cells which are going to be having MHC1? MHC1 is going to be present on all the nucleated cells, or it is also present on the platelets. Whereas if I'm talking about MHC2, what are the cells which we are going to be having MHC2? Please, can you just let me know that? Which cells are going to be having MHC2? That's going to be an easy one. Just answer that for me very, very quickly. Can you just let me know that? MHC2, 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 MHC2. This is going to be associated with expression of MHC2 associated with, MHC2 expression is associated on the antigen presenting cells. On the antigen presenting cells. So that is what we just need to be having an idea. Alright. Okay. Now, whenever you're going to talk about MHC, what is the chromosomal location for MHC? Easy question. Can you just let me know? Chromosomal location of MHC. Okay, Dr. Bill, we are working really hard for it. We expect that this is likely to take place shortly, but every day there are people who are going to be working to ensure that you have a smooth experience with the app. Nonetheless, be assured of the fact it is going to be taking place really shortly. So don't worry on that particular account, right? So when you're talking about B cells, now B cells are going to be responsible for secretion of antibodies. And may I just remind you of the fact that when you're talking about the B cells are going to be secreting different types of antibodies. Which is the first antibody secreted by a B cell? First antibody secreted by a B cell is going to be IgM. Subsequently, the B cells are responsible for secretion of IgA, IgE and IgE. What is this phenomena known as? Answer that for me, guys. For those of you who watch the videos, for those of you who are familiar with the concept, that's an easy question. Every B cell on stimulation or coming in contact with a proteinaceous antigen first secretes IgM, then it is going to secrete IgG, IgA and IgE. So what is this phenomena known as? Initial secretion of IgM followed by secretion of IgG, IgA and IgE. What is this phenomena known as? What is this phenomena known as? Very good. That's an easy one. Okay. So you expected only to, so doctor is the first one to answer that correctly. That's given the name of antibody class switching. So class switching, also known by the name of isotype switching. Class switching, also known by the name of isotype switching, is what we need to be familiar with. That is what we need to have an idea over here. So class switching or isotype switching, right? What is the reason why we need to have this kind of a phenomena taking place? Because you are producing better quality antibodies. And better quality antibodies, the name given to this phenomena is affinity maturation. Affinity maturation. Most of you know about this phenomena taking place, but you did not know the technical term. And that's where the examiners will like to trap you. Right? So please don't expect examiners to always ask you primary immune response में कौन सा antibody होगा. You are happy saying it is IgM. Secondary immune response में कौन सा होगा. You are happy answering it as IgG. They can even ask you this kind of a concept. That's easy. That's not difficult, right? Just ensure the fact that you know about this kind of a situation though. So class switching of antibody, isotype switching or affinity maturation are the terms that you're going to be associating with different types of antibodies. Now what they ask you in exam most commonly, which of these antibodies is going to be playing a role in a person having a history of breathlessness, having a development of a rash, having a development of a lot of itching after an unknown insect bite. Right? So this is going to be typically associated with IgE. So IgE is present on mast cell. And that mast cell is going to be having IgE. IgE cross-linking takes place. So mast cells are going to degranulate. They are going to be having release of histamine. And that's what is going to be causing the trouble in the patients. Right? IgG, IgM. Very, very important in context of activation of the classical pathway of the complement system. When we are going to be talking about IgA, this antibody is going to be beautiful in the sense it's going to be present in a monomeric form. It is also present in a dimeric form. Remember the J chain, the joining chain. That is what we need to remember over here. IgD thankfully not commonly asked in the exam, so they are more than happy if you remember the antibodies in this sequence. Why this sequence? Because IgG present in maximum concentration, IgE present in the lowest concentration. Now just one easy question for me, which is an example of an antibody which is going to be transferred from a pregnant lady to her fetus. Antibody being transferred from a pregnant lady to her fetus. Like, which is the antibody that we are talking about over here? What antibody are we talking about over here? Okay. What antibody are we talking about over here? Antibody which is going to be transferred from the pregnant lady to her fetus. Yeah, exactly. So that is what you need to remember. This is going to be going from the maternal to the fetal circulation. It goes from maternal to the fetal circulation. So that's going to be IgG antibody. I hope that's easy for us to understand. Right? Yeah. Talking about the fact that you're going to be having different types of hypersensitivity reactions, out of which the type 1 is most commonly asked in the exam. It's going to be having a role played by IgE antibody, and typically history, 3 questions given in the exam. So you have an unknown insect bite, you have a question on a patient who's going to be having a development of breathlessness or a trouble because of intake of seafood. You have a question in which a patient is going to be having a bee sting, because of which he's going to be having a development of a crash in the BP. There is going to be intense itching. That is what you need to remember. So that's type 1 hypersensitivity reaction. Type 2 and type 3 dependent upon IgG and IgM, and this is going to be associated with multiple examples. And type 4 is the only one in which there is no role of an antibody, so that's given the name of a cell-mediated hypersensitivity reaction. That's easy. Type 1 examples: ABCD, atopy, bronchial asthma, Cassoni's and drugs like penicillin. Type 2, you are all familiar. Now everybody talks about that. My blood group is Rh positive, so I need not explain it. Whereas we're going to be talking about myasthenia gravis, we're going to be talking about blood transfusion reaction, Graves' disease, Goodpasser syndrome, immune hemolytic anemia, immune thrombocytopenia, right? And you're going to be talking about rheumatic fever, you're going to be talking about hyperacute transplant injection, you talk about pemphigus vulgaris and pernicious anemia. Type 3, sharp, very good. SLE, Schick test, serum sickness. H, Hinox-Schönlein purpura. A, Arthus reaction. R, reactive arthritis. P, polyarthritis nodosa, post-streptococcal glomerulonephritis. Alright, yeah. And when you're talking about type 4, you're going to be having the other name given to type 4, delayed type hypersensitivity reaction. That's exactly what they ask you in the exam. Please don't make a mistake on such questions. They're going to be easy questions that we need to have an idea. Talking about the types of transplant, recent exam question. There's a guy who had developed a kidney failure. He was lucky enough to get a transplant of kidney from his identical twin. So when you're talking about identical twin, that's an example of an isograft. Self-grafting, autograft. If you're going to be taking it from a different individual, let's say the guy takes the kidney from the mother or the father, then that's going to be an example of an allograft. If you're going to be taking it from an animal, that's going to be given the name of a xenograft. That's nothing spectacular over here. Easy fact, but don't make a mistake in the question exam in case they give you a clinical history based question, right? The commonest type of a transplant that is being done so far as organ transplants is concerned is going to be that in context of a patient suffering from CKD. So kidney transplants are being done very commonly, and the kind of a transplant that is being done in the patients usually in case of kidney transplant happens to be an allograft. Having said that, these are the examples of commonly asked immunodeficiency disorders. So that's going to be a question for you. Just quickly answer that for me. Just revise that for me. DJOR syndrome is going to be causing involvement of which immune cells? Patients are going to be having the involvement of T cells. Classically, decreased T cell activity. At the same time, these patients are going to be having a development of hypocalcemia. If I'm talking about Bruton's disease, it's a B cell disease. As simple as that. If I'm talking about SCID, recent exam question, you have a problem with both B as well as with T cells. That is what you need to have an idea about over here, right? So that's going to be easy. If I'm talking about autoimmune disorders, that's going to be easy for most of you to pick up. Anti-topoisomerase antibody. What is the condition that comes to your mind? So if I just label them as 1, 2, 3 and 4, match the following. Extended match questions, very much expected in the screening exam any day. So don't get shocked if such questions are going to be asked in the exam, because that's a trend where you need to be familiar with that. That anti-topoisomerase antibody is something that you see in a patient who's going to be suffering from a condition, and the condition that the patient is going to be suffering from is given the name of systemic sclerosis. Anti-topoisomerase antibody, systemic sclerosis. If I'm talking about anti-centromeric antibody, yes, you see it in a patient having CREST syndrome. ANA anti-Smith antibody, SLE. Anti-beta 2 glycoprotein antibody, APLA syndrome. What's the antibody that is going to be seen in a patient suffering from MCTD? Mixed connective tissue disorder. Just answer that for me very quickly. MCTD, what is the nature of the antibody? Also, let me know what is the nature of the antibody in a patient suffering from Hashimoto's disease. Yeah, very good. You know that. MCTD, mixed connective tissue disorder. What is the nature of the antibody over here? Okay, so MCTD, the patients are going to be having ribonucleoprotein antibodies. And when I'm talking about Hashimoto's, what is the nature of the antibody? Can you just let me know, guys? Yeah, that's easy. Okay. So every time you don't expect to get a question on SLE, though it is the commonest asked question, let me assure you that. But at the same time, please don't always expect to get a question in the exam asking you about the presence of a non-erosive arthritis, presence of a photosensitive skin rash, presence of a patient who's going to be having a multi-system disorder. You can be having it in case of other conditions as well. Dr. Sudhanshu, that's going to be primarily covered in biochem, but yes, given the constraint of the time, there are other topics which are likely to be uploaded prior to that. Yes. So we're talking about Hashimoto's thyroiditis patients. They're going to be having a development of anti-TPO antibody. I don't know why nobody answered that. I mean, Sushil answered that. Very good. Rajesh. Okay. Medico. So Medico VH, Rajesh, Sushil Kumar, Astha Verma, Mani. Okay. Okay. Right. So that that is what we need to have an idea so far as Hashimoto's is concerned. So those are the important examples of autoimmune disorders. Why do we get autoimmune disorders? That is what you need to remember. Okay, why do we get autoimmune disorders? That is what is going to be asked to us as a question in the exam, and these are going to be seen because of the presence of autoimmune disorders, because of the fact that there is going to be a development of failure of tolerance. So failure of tolerance is going to result in development of autoimmune disorders. Easy ones that we are asked in the exam. Classification of amyloidosis. Fairly easy question. You can't go to an exam, especially any kind of a I would say a NEET PG, INISET or a FMGE kind of an exam without having a look at the table of amyloidosis, because that's an ultra high table that you need to have an idea about, right? So when I'm talking about primary amyloidosis associated with multiple myeloma, chemical nature of the amyloid happens to be AL. Now answer my question. What is the commonest organ affected in a patient suffering from multiple myeloma in context of involvement of amyloidosis? So primary amyloidosis, multiple myeloma, what is the commonest organ affected in the patients? What's the commonest organ affected in the patients? That's easy. Most of you know that, right? Most of you know that. Please let me know. Guys, wrote the answer. Okay. Rajesh, you completed the whole syllabus, but you are feeling low. Why should you feel low about it here? I mean, just ensure the fact that you are revising it as much as you possibly can. Simple advice to FMGE is just believe in yourself and just crack the exam. As simple as that. Don't listen to too many stories. Don't listen to too many naysayers. Nowadays, people are always going to be telling you something or the other. The exam is this and that. But then just a simple thing. Believe yourself. You have come this far only on your own efforts. So there's a very good possibility that you're going to be doing well in your subsequent exams as well. So in primary amyloidosis, you're going to be having the cardiac involvement as an important thing. In secondary amyloidosis, you're going to be having the example associated with chronic inflammation. You can also associate it with conditions like different types of cancers, right? And the chemical nature of the amyloid over here happens to be the AA type of amyloidosis, right? Secondary amyloidosis, classically the patients are going to be having the most important involvement of, and that is what you need to remember for the exam perspective, these patients are going to be having the involvement of the renal system, the kidneys. Hemodialysis, you are going to be having the involvement which is going to be seen in association with the chemical nature of the amyloid being A beta to M. When you're talking about the familial amyloidotic polyneuropathy, you're going to be having a mutant form of transthyretin in these patients. That's going to be ATTR. Wild type, that means normal type of transthyretin, is going to be seen as a feature of senile cardiac amyloidosis. Any patient having Alzheimer's disease, remember the fact A amyloid, B, one brain, one B, Alzheimer's is going to be associated with A beta, right? You could be given a question in the exam which is talking about the fact the patient is going to be suffering from prion disease, APRPC. Right, APRPC, amyloid prion protein is going to be getting deposited over here, APRP. If I'm talking about something that is going to be an endocrine problem, of course you need to remember about type 2 diabetes, in which patients are going to be having the development of deposition of islet associated pancreatic polypeptide, AIAPP. And if I'm talking about a thyroid dysfunction, you need to be familiar with the development of medullary thyroid cancer, So you need to be familiar with the fact patients having medullary thyroid cancer are going to be having the development of amyloid, and the chemical nature of the amyloid over here happens to be ACAL. A for amyloid, CAL for calcitonin. Alright, that is just a simple fact that we need to be familiar with. Now revise for me, what's the first part in the liver where amyloid is going to get deposited? Answer that as quickly as possible. In the liver, the first part where the amyloid is going to get deposited is going to be, yes, a lot of you know that answer, and I'm sure you are very, very clear with that fact. Liver is going to be having the first deposition of amyloid in what is being given the name of space of Deci. What's the first space in the kidney where amyloid is being deposited? Very good, mesangium. You need to remember that as mesangium. What's the first place in the heart where amyloid is going to get deposited? Subendocardial area. So you are familiar with the involvement of the spleen as well. Red pulp and white pulp of the spleen. Lardaceous spleen, sago spleen respectively. Red pulp, you're having lardaceous spleen. Sago spleen, white pulp, that is what you need to be familiar with, right? Right, okay. So that is what they'll have to ask you as a question. Now, I mean, no discussion of amyloid can ever be complete by any teacher in the world without having a discussion about something that is going to be given the name of the histological appearance of amyloid. So you're going to be having this kind of an appearance, name of the stain, Congo red, Congo red. But under normal light, Congo red is going to be giving you a pink red appearance, pink red, hyaline-like appearance. And when I'm going to be talking about the same Congo red, under polarized light, it is going to be giving what kind of an appearance? This kind of an appearance, which is going to be given the name of a apple green birefringence. Which of these two appearances is more characteristic of amyloid? Of course, apple green birefringence. Why do we have apple green birefringence? Because of the beta pleated structure. Beta pleated structure. What is the composition of amyloid if I watch it under electron microscope? So I find long fibrils, non-branching fibrils. Read the question in the exam carefully. It has foxed a lot of people in the exam as to what is the appearance of the amyloid with respect to the normal light. What's the appearance of amyloid under polarized light? What's the appearance in electron microscopy? What's the appearance in spectroscopy? What's the appearance that you're going to be getting in case of X-ray crystallography? So whatever technique they ask you in the exam, accordingly answer that question, right? That's an easy one that we need to be having an idea. Now, if I ask you a question, familial Mediterranean fever, what's the chemical nature of the amyloid? Answer that quickly, guys. Familial Mediterranean fever. What's the chemical nature of the amyloid over here? Familial Mediterranean fever. So when you are going to be having a patient who's going to be having a fever, of course, the patients are going to be having the presence of an inflammation. And when they are having an inflammation, the chemical nature of the amyloid obviously is going to be double A. Double A. So familial Mediterranean fever, the chemical nature of the amyloid is going to be double A. A lot of you didn't answer that as quickly as I expected you to be familiar with. No worries. Shifting our attention to cancers or neoplasia. Those are the four things that they'll have to ask in the exam. So doctor, I didn't ask you about the name of the protein over here. I just asked you the name of the chemical nature of the amyloid over here, right? All right. So when I'm talking about anaplasia, that's going to be given the name of too many lights over here, so perhaps the temperature rose a bit, and therefore just to make myself a bit more comfortable, hallmark of, this was a hallmark of malignant transformation. Hallmark of malignant transformation, that's going to be anaplasia. They asked you a very easy question this time around, wherein it asked you what is the meaning of anaplasia. So meaning of anaplasia simply means there is a loss of differentiation. Absence of differentiation is what is going to be given the name of anaplasia. Is anaplasia reversible? The answer is no. It's an example of an irreversible change. If I'm talking about rate of growth happens to be really massive. Now cancer cells are dependent upon carbon intermediates for their rapid rate of growth. Carbon intermediates are required for rapid rate of growth of the cancer cells. What is the phenomena which is because of which the cancer cells are going to be getting these growth factors? Answer that quickly, guys. What is the reason why the cancer cells are going to be getting the carbon intermediates as growth factors? What is the source of the carbon intermediates? What mechanism are we talking about over here? The mechanism we are talking about over here is going to be given the name of Warburg effect. So when you read about that particular thing in radiology, you are going to be associating that with something given the name of a PET scan, and that's going to be associated with administration of something given the name of 18-FDG. 18-FDG. Alright? And when you're talking about invasion, the important thing about invasion that tumor cells have a tendency that they are going to be causing infiltration or involvement of the different areas in the body. That's what we need to have an idea about over here. Right? That's what we need to be familiar with. What is the importance of knowing about metastasis? Importance of knowing about metastasis happens to be the fact this happens to be the most reliable feature of malignancy. Most reliable feature of malignancy. So if you are going to be talking about a tumor which is going to be having metastasis, for sure you are familiar with the fact you're not dealing with something which is going to be absolutely normal. We are dealing with something which is going to be a very reliable feature of malignancy. That's what I am talking about over here. So those are the important terms that they'll have to ask in the exam with respect to neoplasia. Now other thing that we need to be familiar with is metastasis can take place through multiple areas. Now if I ask you a question, example of a tumor which is going to be malignant in nature, that's what they did for you in the NEET exam as well and the couple of exams in the FMGE exam as well. Malignant tumor but having no metastasis. Answer that quickly, guys. Malignant tumor but not having metastasis. Malignant tumor but not having metastasis. Can you just answer that? Malignant tumor but not having metastasis. Very good. Yes, doctor. Glioma and rodent ulcer. Exactly. So a glioma, which is an example of a CNS tumor, and we are talking about basal cell carcinoma. They both are malignant tumors but they don't have metastasis. That is what we need to remember over here. That's easy. Talking about the next one, cell cycle and regulation. So whenever I think in terms of cell cycle, I always tend to become a bit more nostalgic for the simple reason I just remember my favorite batsman, and that is MSD, Mahendra Singh Dhoni. So he was the only one, he was an Akela batsman, he was the only beautiful guy you know who helped us win the cricket World Cup in all the 3 formats, and therefore I always keep on talking about him that Dhoni was a Akela batsman. Dhoni एक अकेला batsman था जिसने हमें मैच जिताया हर फॉर्मेट के अंदर. So Dhoni also helps us crack a lot of questions in the exam because Dhoni stands for over here. This is going to be the sequence of the cyclins and of course the CDKs which you are aware. So Dhoni coming to bat himself, helicopter shot, you remember 4 runs and 6s, then quickies 2 runs and then 1. So 4-2-2-1, that's the name of the cyclin dependent kinases about which we need to have an idea. Because we are talking about the first cyclin over here, that's going to be the most important cyclin. That's going to be cyclin D that we need to remember so far as the cell cycle regulation is concerned. Of course, when you're talking about the cell cycle, we need to be familiar with the checkpoints over here as well. So the G1S checkpoint, that's going to be under the regulatory influence of RB as well as P53. We're going to be talking about the G2M checkpoint, that's under the influence of P53 and not by RB. That's what you just need to remember over here. And the most important one that we need to be familiar with is over here, cyclin D and the CDK46. Yeah, right? Yes, Dr. Krishna, absolutely agree with you. Now, cyclin D1 overactivity. Cyclin D1 overactivity is what you associate with breast cancer. You associate in a patient suffering from esophageal cancer, and cyclin D1 activity is going to be associated with. Now, that's an easy question. You would associate it with an example of which type of a lymphoma? Cyclin D1 overexpression is a feature of which type of a lymphoma? Yes, a lot of you talk about that correctly. So MSD wears a mantle, and when you say mantle, it's going to be answered in the exam as mantle cell lymphoma. Mantle cell lymphoma. So mantle cell lymphoma is what you associate with cyclin D overexpression. That's an easy thing for us to remember. Now when you talk about genes, 4 categories of genes: proto-oncogenes, tumor suppressor genes, apoptosis regulatory genes, and the defect in the or the DNA repair genes. So when you're talking about the proto-oncogenes, single mutation causes increased risk of cancer. Most important proto-oncogene that you need to remember over here happens to be the RAS gene. So RAS gene associated with the downward activation of the MAP kinase, the farnesyl movement, all that is known to you. When you're talking about RAS, you associated with KRAS associated with, I'm talking about the most important one example only, KRAS associated with colon cancer. KRAS, colon cancer. ABL associated with BCR, ABL, you associate with a patient suffering from CML, Philadelphia chromosome. MYC, remember CMYC, Burkitt's lymphoma. RET gene associated with a patient who's going to be suffering from a tumor, that's going to be the medullary thyroid cancer. HER2/neu, an easy one, breast cancer, trastuzumab, pertuzumab, you have heard about all those names. Tumor suppressor genes are important. Why? For the simple fact, the tumor suppressor genes, both the gene copies have to be mutated for development of cancer. RB gene, the most important tumor suppressor gene seen in human cancers, also having an association with the tumor that they asked in the exam recently, retinoblastoma. APC, colon cancer. FAP is what you need to remember. VHL, von Hippel-Lindau syndrome. Renal cell carcinoma, patients are at high risk for development of pheochromocytoma as well. When you're talking about WT1, Wilms tumor. BRCA1 and 2 associated with breast cancer. BRCA1 with female breast cancer. BRCA2 associated with male breast cancer. That is for our quick revision. We already had a discussion about Li-Fraumeni syndrome as well as B-cell lymphoma, which is follicular lymphoma, right? Of course, yes, Knutson's hypothesis associated with RB gene. So just quickly talking about the facts that you need to be familiar with over here, right? Defect in DNA repair can be a problem at the level of nucleotide excision repair gene. This can be associated with xeroderma pigmentosa. If I'm talking about the trouble at the level of mismatch repair, this can be associated with HNPCC or Lynch syndrome. If I'm talking about recombination problem, that can be seen as a feature of Bloom syndrome, ataxia telangiectasia, and Fanconi syndrome. So those are all important questions which have been asked in the exam earlier. More commonly, your examiners love to ask you about xeroderma pigmentosum. That's essential. Please be familiar with the fact examiners do ask you a question on something like ataxia telangiectasia as the next important thing. And of course, they can any day ask a question on something like HNPCC, because HNPCC can be associated with the development of colon cancer in the patients, particularly right-sided colon cancer. You know about that? So answer for me, which is an example of a enzyme which is responsible for causing immortality of cancer cells? Can you just let me know about this answer, guys? The second answer is what is known to already most of you. Aerobic glycolysis is what you associate with the term Warburg effect. Aerobic glycolysis, Warburg effect. But immortality of cancer cells is going to be seen because of the fact that there is going to be a reactivation of an enzyme that's going to be given the name of telomerase. Last to last exams question. If I'm talking about etiological factors of cancer, of course, these are the 3 common ones which have been asked in the exam recently. Arsenic exposure associated with the risk or development of skin cancer, that was one question. Arsenic exposure also causes development of hepatic angiosarcoma. That is what we need to remember over here. That's the other thing that we need to be familiar with. If I'm talking about benzene, benzene causes blood cancer. Benzene causes blood cancer. That means the patients are at high risk of suffering from leukemias. That was a question asked in the exam. Asbestos exposure is responsible for causing development of what kind of a cancer? It can be responsible for causing a cancer like mesothelioma specifically in the thoracic cavity, can be responsible for causing bronchogenic cancer as well. Radiation exposure in terms of ultraviolet light can be responsible for causing skin cancer, particularly a dangerous group of patients. The patients who are at high risk of development of such cancers would include the patients who are having the development of a nucleotide excision repair gene defect. Microorganisms, easy. That is a question asked in the exam. H. pylori. What are the 2 common examples of cancers? Answer that quickly, guys. Answer that quickly. Alright. H. pylori associated with gastric adenocarcinoma. Also associated with a tumor that's going to be given the name of maltoma. 2 tumors with which you associate H. pylori infection. If I'm talking about something that is going to be given the name of human papilloma virus, all sexually transmitted cancers. So recent exam question. You associated with a patient who's going to be suffering from cervical cancer, head and neck cancer, patients who are going to be having oral cancer, patients who are going to be having anal cancer. Be familiar with the fact when you're talking about HPV, the problem in the patients is going to be because of E6 and E7. 3 times asked question. Underactivity of P53, underactivity of RB gene that causes cancer. If I'm talking about Epstein-Barr virus causes 4 types of cancers: Hodgkin's, non-Hodgkin's, Burkitt's lymphoma, nasopharyngeal carcinoma. 3 cancers are B cancers. Nasopharyngeal carcinoma is an example of a T-cell cancer. What's the entry point of the virus, Epstein-Barr virus? That's because of a molecule called as CD21. Where do we have CD21? CD21 is present on the B cells, right? When I'm talking about Clonorchis sinensis, recent exam question, that's easy one. Deliberately I'm not talking about the answer. Can you just let me know? Clonorchis sinensis, okay? What is going to be the cancer which comes to your mind if I say a patient is suffering from infection caused by Clonorchis sinensis? Answer that quickly, guys. Answer that quickly. That's going to be easy. Clonorchis sinensis, yes, that is going to be associated with the biliary tract cancer. So biliary tract cancer is what is going to be given the name of cholangiocarcinoma. Cholangiocarcinoma. That was a neat PG question. Easy one at that, right? Talking and thinking in perspective of the diagnosis of cancers, perhaps a very important example of a video which I would recommend you to go back and have a look at it. But then I wanted to be familiar with the different types of tumor markers. CA125 is specifically useful for making a diagnosis of ovarian cancer. CA199 pretty importantly for making a diagnosis of pancreatic cancer. Couple of years back they asked you this question. Instead of pancreatic cancer, if pancreatic cancer not given as an option in the exam, please take the answer as colon cancer. If you're talking about CA153 and CA2729, they are for breast cancer. Beta HCG is a tumor marker for germ cell tumors as well as for choriocarcinoma. CD99, now that is what I wanted to answer in the chat box. I understand a lot of people might be thinking that they know about a lot of stuff. It's always good if you know the answer, but at the same time, there's no harm in having a revision. So CD99 is going to be a marker for, very good. CD99 is a marker for, yes. Perhaps a lot of you would be able to remember a cursor over here as well. We are thinking in terms of a cancer that's going to be associated with the other name of CD99, that is MIC2. MIC2 or CD99 is a marker for Ewing sarcoma. It's going to be for Ewing sarcoma. That's what you need to remember. Dr. Ankit, it is not GCT, it is Ewing sarcoma. Just remember that basic fact. When I'm talking about something which is going to be given the name of ALK, that is anaplastic lymphoma kinase. This is going to be seen in a patient who's going to be suffering from a tumor. It can be seen in a patient suffering from lung cancer, or it can be seen in a patient who's going to be suffering from a tumor, inflammatory myofibroblastic tumor. So ALK is the question which was asked in the recent exam. That is about which we need to have an idea. Intermediate filaments. After a long duration of time, questions on the exam are being asked regularly on intermediate filaments. So if I'm talking about the marker that we are having for something like a myogenic tumor, which of these is going to be your choice of intermediate filament? Myogenic tumor. Answer that for me, guys. Myogenic tumor, muscle origin tumor. Muscle origin tumor, remember the fact you're going to be having a marker as desmin. If I'm talking about keratin, that's a marker for carcinoma. If I'm talking about mesenchymal tumor means the question in the exam will talk about sarcoma. So when he's talking about sarcoma, he's talking about something like vimentin. That is what you need to have an idea. If I'm talking about paraneoplastic syndrome, of course, these are one of the commonest ones. Hypercalcemia, you associated with what type of cancer? Squamous cell lung cancer. Cushing syndrome, SIADH, you associated with which type of a cancer? Small cell lung cancer. So those are the easy ones that you need to have an idea. quickly rush through this type of a, I would say slide or this kind of a video, because you just need to keep on revising. Okay, this is what I know, this is what I know, this is what I know. Okay, this is what I forgot, this is what I'm not able to recall. That's the only way by which you're going to be having a quick revision. I repeat, this is not a substitute for either your main videos or a substitute for your Cerebellum rapid revision, but at the same time, just for the feel good factor, yes I know this, yes I don't know this. So if you know it, very well. If you don't know it, that's an area that you have identified, it's a gray area for your preparation. That is what you have to kind of brush up. Talking about this as an example, acanthosis nigricans. What is the cancer which comes to my mind? What cancer comes to my mind? That can be an example of an image-based question. Similarly, I am having a patient who's also going to be having seborrheic keratosis. What's the cancer which I am thinking in terms of a patient having this presentation? Acanthosis nigricans, or a patient is going to be having seborrheic keratosis. What's the cancer I'm thinking about? Right? Talk about that. Both these are present in the same patient, let me say. So patient came to your clinic and he says, Doc, I'm having the presence of a hyperpigmentation in the axillary area. And you're going to be having a velvety appearance of the underarms. At the same time, when you ask the patient to remove the clothing from the back, he was having the presence of multiple seborrheic keratosis. What's the cancer that he is suffering from? Yes, pretty good. So a lot of you are talking about the answer correctly. Dr. Ankit Kumar, the first one to say that correctly. The most common cancer which would come to my mind over here happens to be stomach cancer, gastric adenocarcinoma. That's an important thing to remember. That's going to be adenocarcinoma. That's going to be gastric adenocarcinoma, what I want to be familiar with over here. Of course, might as well be seen uncommonly in a patient who's going to be having the other cancers, but the first cancer which I would think as a differential diagnosis is going to be stomach cancer. This kind of a multiple seborrheic keratosis is also going to be given the name of sign of lesser Trallat. Sign of lesser Trallat. So just a fascinating way to fox you or confuse you in the exam. Sign of lesser Trallat is what you associate with multiple seborrheic keratosis, most commonly associated with stomach cancer. Now, obviously, next best you can go in for would be something like a lung cancer. Next best you can be associating it with something like a uterine cancer as well. But sign of lesser Trallat is multiple seborrheic keratosis, and the first thing that you need to remember over here is going to be a patient suffering from the gastric carcinoma. Having said that, just have a quick revision about what they can ask in the exam with respect to hematology. So in hematology, they would start off with a discussion like anemias, small size RBCs, a feature of, right? Hi, Dr. Prabodh. No, I can only be a facilitator, my friend. Don't worry. You are a doctor because of your own efforts and the best wishes of your parents and the Almighty. Maybe I helped you at some point of time, and I hope I help more people like you, but then I would be acting only as a catalyst. It was your effort which had given you the fruits. So microcytic anemia is going to be associated with the standard acronym. Everybody talks about that, right? SITA, sideroblastic anemia, iron deficiency anemia, thalassemia, and anemia of chronic disease. If I'm talking about big size RBCs, yes, you're talking about macrocytic anemia. So you can be having it in a patient suffering from liver disease. You can also be having this as an example of a megaloblastic anemia. That means megaloblastic anemia simply means the patients are going to be having a problem at the level of nuclear maturation, which can be seen because of a problem at the level of B12 or folic acid. B12 or folic acid, right? So that is what we need to have an idea about over here. Having said that, be familiar with the fact that what can be the important things that they can ask on the exam, or what can be the important hints which are going to be given to you in the exam regarding this kind of a question. So if I'm talking about a microcytic hypochromic anemia, I mean, we are always talking about something like iron profile, serum ferritin, serum iron, percentage transferrin saturation, and TIBC. This one single slide will help you crack 5 questions. So all of these are going to be reduced in a patient who's going to be having what? All are reduced. Everything is going to be reduced except TIBC. So if I say serum ferritin is down, serum iron is down, percentage transferrin saturation is down, but TIBC is going to be increased. So that's the diagnosis. Your diagnosis is going to be iron deficiency anemia. Question number 2. If I'm talking about a PAT, all are going to be reduced except serum ferritin. So serum iron is down, percentage transferrin saturation is down, TIBC is down, but my patient is going to be having increased concentration of serum ferritin. This is going to be a patient suffering from anemia of chronic disease. Anemia of chronic disease. Remember that fact. If I'm talking about all of these are going to be normal, I'm talking about a patient having a microcytic anemia. I'm thinking about a patient who's going to be suffering from thalassemia trait. Remember that fact. Point number 4. I'm thinking about everything is increased. Everything is increased. Ferritin is increased. Iron is increased. Percentage transferrin saturation is increased. But TIBC is going down. What am I talking about? I'm talking about sideroblastic anemia. Sideroblastic anemia. Alright. So that's going to be an easy question. That is what you need to be familiar with for this. Watch out for this kind of a slide. The other things I can help you remember in the exams can be keywords. So if I'm talking about a patient who's going to be having a presence of a pica or coelonychia, what I'm thinking in terms of is iron deficiency anemia. If I'm thinking about a child and the question says the child was having the presence of a worm infection, I'm thinking in terms of again iron deficiency anemia, very, very commonly associated. In the question which is talking about the presence of megaloblast, That means the patient could be having the presence of something like a hypersegmented neutrophil. So he is going to be having a megaloblastic anemia. So hypersegmented neutrophils means we are talking about megaloblastic anemia. Now if a question says the patient was a vegan, or let's say the patient was having a fish tapeworm infection, I am thinking in terms of a B12 deficiency. The question says patient is going to be having megaloblastic anemia, or he was having presence of hypersegmented neutrophil, and my patient was having the presence of neurological symptoms. I will again think in terms of B12 deficiency. But if the question says my patient was having megaloblastic anemia, he was not having any neurological symptoms, or my patient was said to be having a history of a lot of liquor consumption, alcohol consumption, or the question says my patient was not consuming sufficient amount of vegetables and fruits, then I'm thinking in terms of folic acid deficiency, folate deficiency. That one slide will help you crack 6 questions for your exam for sure. That's the only thing I wanted to be familiar with over here. Same thing can be asked in a twisted way where they give you image-based questions. So when I'm thinking in terms of a patient who's going to be having a microcytic hypochromic anemia, the question says presence of koilonychia, I think in terms of iron deficiency anemia. If I'm given a question in the exam which says hypersegmented neutrophil, that's a high image I wanted to keep in mind. Presence of 5 or more than 5 nuclear lobes in the neutrophil, that is hypersegmented neutrophil. If I say neurological symptoms are also present, this is B12 deficiency. If I say patients were not having neurological symptoms but only having hypersegmented neutrophils, I'm thinking in terms of B9 deficiency, that means folic acid deficiency. So that's an easy trick or an easy way to crack the questions in the exam. Similarly, talking about a question which is saying patients were having the presence of spherical RBCs. Spherical RBCs present in the peripheral smear, the most common cause, autoimmune hemolytic anemia. Now if the question says there were antibodies which were getting attached with the RBCs at body temperature, so this was an example of a warm subtype of autoimmune hemolytic anemia, can be associated with conditions like CLL, condition like SLE, can be associated with drugs. If the question says antibodies are attaching at a cold temperature, I will associate this cold autoimmune hemolytic anemia, which can be seen in a patient suffering from mycoplasma infection, can be seen in a patient who is going to be suffering from a condition that is going to be given the name of a B-cell lymphoma, or can be associated with the patient who is going to be suffering from a condition like infectious mononucleosis. Any patient who is going to be having autoimmune hemolytic anemia, very typically the patients are going to be having the presence of a positive Coombs test. If I'm talking about hereditary spherocytosis, this patient is going to be having a problem at the level of RBC membrane protein. Typically the patients are going to be having a trouble at the level of enchirin, and there is going to be a positive family history. G6PD deficiency, classically the question will make a mention of these findings. Identify the findings that you are associating it over here. So these findings are presence of what is given the name of bite cells, very high stuff, or the patients are going to be having presence of structures which are going to be denatured hemoglobin, which is going to be given the name of Heinz body. So bite cells or Heinz body associated with G6PD deficiency is what I wanted to be clear with. Typical question given in the exam, this guy was having the presence of a malaria-like infection. He was given an anti-malarial drug, which was also including a drug like primaquine, and then this guy was having a development of trouble like this. So this is quite suggestive of the fact the patient was having a G6PD deficiency. Another cause of hemolytic anemia which the examiners would love to ask you is going to be a patient who's going to be having a presentation in a painful crisis. Afro-American child, non-healing ulcer in the foot. He was having presence of abdominal pain. He was having a presence of a chest discomfort. On the peripheral smear, he was having the presence of crescent-shaped RBCs, or he was having the presence of sickle-shaped RBCs. So this is going to be a child suffering from sickle cell anemia. Now if I ask you a basic question, child having sickle cell anemia is having a development of osteomyelitis. What is the causative organism? Answer that quickly, guys. Answer that quickly. Patient is going to be having the development of osteomyelitis because of sickle cell anemia. What is the cause of the osteomyelitis? So this patient is going to be having a development of the infection caused by osteomyelitis caused by salmonella. Remember, when we are going to be talking about infection like osteomyelitis in a child, the typical organism is going to be Staph aureus typically, but in sickle cell anemia it is going to be salmonella. If I'm talking about a child who's going to be having this kind of a picture, your examiners have given you this question 3 times in the exam. Hepatomegaly, splenomegaly. You have the presence of microcytic hypochromic cells. You are having presence of cells which are going to be having an appearance that's given the name of target cells, and you're going to be having an extracellular appearance having the presence of a crew-cut appearance. The child was also having a history of multiple blood transfusions since birth. You are dealing with a child who's going to be suffering from a condition that's given the name of Thal major. Thal major. So the clinical history is what is very relevant for you to be able to pick up in the exam. That's what is going to be a catching thing for you so as to crack questions. Gone are the days. They will not ask you a question on the example of a kind of a point mutation, or they'll talk about only the peripheral smear. Clinical history in totality is what you need to understand for cracking more questions in the exam. So make sure that you're aware about such histories which I've shared with you. Malaria kind of a history, or crescent shape, or with something like this kind of a history, something like thalassemia. Having said that, a patient is going to be having a short history and having a development of features suggestive of pancytopenia. Say for example, the patient is going to be having features of anemia, bleeding tendency, fever, as well as this patient is going to be having hepatosplenomegaly and lymphadenopathy. So when you have a short history, that's an acute history, and when you're having such kind of pancytopenia, this could be an example of an acute leukemia. Now depending on the cell, you could be having cells which are going to be containing granules or the presence of abnormal air rods over here, abnormal eosinophilic granules. This is going to be a patient suffering from AML. You can be having the presence of a non-granular cytoplasm. You can be having condensed cytoplasm over here, smaller cells to some extent. That's going to be a feature of ALL. So different types of questions that they put up to in the exam with a similar history. ALL, the important fact that you need to remember, commonest blood cancer that you have in case of children. AML, the important fact that you need to remember, AML M3, nowadays called as APL, associated with the translocation 15-17, very high risk of development of DIC, and that causes death in the patient. So just watch out for the fact that we make a diagnosis of acute leukemias on the clinical history. 3 times they gave you this kind of a history, short history. The child was having hepatosplenomegaly, sternal tenderness, development of features of pancytopenia, and they were having the manifestations in the form of either myeloblast, so that was AML, or they were having lymphoblast, so that was ALL. That is what you need to have an idea. A long-standing history for many years, insidious history, patient doesn't know he has a cancer, can be associated with something that is going to be given the name of a chronic leukemia. Now if they give you a peripheral smear image where they're going to show you presence of smudge cells, question says smudge cells, think in terms of CLL. This guy is going to be having the presence of an insidious history, is having the peripheral smear smudge cells. He's going to be having recurrent attacks of infections. He's going to be having tumor cells which are going to be having a similar appearance. So he's going to be having the appearance of the school going, the convent girl appearance. In contrast, I have a patient who's going to be having the presence of massive splenomegaly. Peripheral smear shows me presence of different stages of myeloid maturation. This is very characteristically associated with the presence of what is going to be given the name of flower-like appearance, right? So instead of the convent girl appearance, we are having a college girl appearance, also associated with basophilia, eosinophilia. This is going to be CML. CML, what is the translocation? Very good, 922. Multiple times asked question, what's the name of the chromosome? Philadelphia chromosome. Recent NEET PG question. Patients are going to be having the presence of cells which are going to be having a crumpled tissue paper appearance. That's going to be given the name of, yes, this is going to be given the name of a pseudo-Gaucher cell. CML patients having a crumpled tissue appearance, that is going to be given the name of a pseudo-Gaucher cell. So pseudo-Gaucher cell is what you associate with CML. In case of a patient having CML, you treat it with the help of a drug. That's going to be the first example of a targeted anti-cancer drug. That's going to be imatinib. So that's easy that you need to be just remember, right? That's what you need to be familiar with. So yes, Dr. Srishti, Dr. Rajesh, Dr. Aftab, yes, Dr. Positive Vibe, yes. Dr. Krishna Upadhyay, Dr. Alok, Dr. Rajesh, yes, that's what you need to be familiar with. Watch out for the histories in the exam, and then they can ask you questions. Again, a recent exam question, if you had a recall of January 23 as well, you got a question which they were talking about something like the presence of a grape-like cells, and that is what is going to be seen in a patient suffering from multiple myeloma. The patients could be having the presence of a pinkish or a fiery cytoplasm. That's going to be given the name of a flame cell. You could be having a presence of intranuclear or intracytoplasmic inclusions. That's given the name of the Dutcher body and the Russell body. The fact that you need to remember over here is these are example of plasma cell cancers, and the patients are going to be having immunoglobulin like inclusions which is present in them. So that is what you associate with a patient who's going to be suffering from multiple myeloma. What is going to be the prognostic factor for multiple myeloma? So many times asked question, it's the serum beta 2 microglobulin levels. Higher the levels, poorer is the prognosis of the patient. That's an easy thing that you need to be familiar with, right? Having said that, that's an easy thing that they ask in the exam. That's a classical history. Painless cervical lymphadenopathy along with presence of fever, along with weight loss, along with fatigue, and you're going to be having a lymph node biopsy which is going to be showing you the presence of an owl-eye appearance. Yes, you know the name of the cell now. It's a Reed-Sternberg cell. What are the markers? CD15 and CD30. How do you make a diagnosis of this kind of tumor? That's going to be Hodgkin's lymphoma. Now answer that easy question for me. Which type of Hodgkin lymphoma is overall going to be having the best prognosis? Can I just get the answers? Yes, you know the answer, guys. What is the type of Hodgkin's lymphoma which is going to be having overall the best prognosis? I'm talking about the best prognosis. So when you talk about the prognosis, yes, Dr. Alok, Dr. Aftab, Dr. Blood, Dr. Rajesh, Dr. Sara, Dr. Krishna, very good. Just try that out. The best prognosis is what you associate with what is given the name of the non-classical Hodgkin's lymphoma. Non-classical Hodgkin's lymphoma. And when I say non-classical Hodgkin's lymphoma, what I'm referring to over here is lymphocyte predominant Hodgkin lymphoma, the one which is going to be having the presence of cells which are going to be given the name of lymphohistiocytic cell, also given the name of the popcorn cell. Remember that. Very, very high stuff. Having said that, that's a giveaway kind of image now. So very commonly asked in the Indian exams, all type of exams, that you would be making a blunder if you're not able to recall this image. African child having a jaw mass is going to be having a protrusion of a jaw mass like this. On the biopsy, he was having the presence of dark background of tumor cells. In the intermittent areas, you are having the presence of macrophages, which are going to be performing the function of the phagocytosis. So that's going to be associated with the term starry sky appearance. Starry sky appearance. And the moment I say starry sky appearance, obviously the answer becomes over here Burkitt's lymphoma. When I say Burkitt's lymphoma, the kind of gene involved over here, that's going to be the c-MYC gene. So that's a very giveaway kind of a question. Don't make a mistake on that question. That's a humble request. I mean, I'm just literally folding my hands. Please don't make a mistake on that kind of a question. So you know about mantle cell lymphoma, overexpression of cyclin D1. You know about follicular lymphoma, overexpression of BCL2. You know about Burkitt's, which is going to be having the presence of a jaw mass, having a starry sky appearance. You also know about an example of the commonest non-Hodgkin lymphoma, which is going to be the diffuse large B-cell lymphoma. And of course, Hodgkin's is something which all of us read and all of us have to get correct in the exam, right? So all you wonderful people who are watching this video, whether you're in the live or whether you're going to be watching it afterwards, my humble request is don't make any kind of a mistake in such a question in the exam. These are the kind of questions which will, I would say free marks in a way, which are going to be given to you. Having said that, talking about bleeding disorders, either we're going to be having a history of a trauma, or we're going to be having the presence of a deep tissue bleeding suggestive of hemophilias. The commonest hemophilia that we talk about over here happens to be hemophilia A, which is also being given the name of the factor 8 deficiency. Then we talk about hemophilia B, that is factor 9 deficiency. Both these conditions characterized by the patients having isolated elevated values of APTT. If I'm talking about platelet disorders, no history of trauma, superficial spontaneous bleeding. Typically, the patients are going to be having skin and mucosal bleeding, PTK, purpura, ecchymosis. And platelet disorders characterized by the fact the patients are going to be having the bleeding time, which is going to be elevated. The platelet count of these patients are going to be either normal or it can be reduced depending upon whether it is a thrombocytopenic disorder or whether that's an example of a functional platelet disorder, right? We can be having a situation in which the characteristic profile of the patient is going to be mentioned as something like this. So the question will make a mention of the fact, and I want you to identify this kind of a disorder. Patients are going to be having this kind of a profile. Bleeding time is increased, right? Platelet count is going to be normal. The patients are having a normal prothrombin time and the patients are having elevated APTT. What's the disorder I'm talking about? What's the disorder I'm talking about? Yes, guys, you already know it. Very good. What's the disorder I'm talking about? Okay, Dr. Yashwant, yes, that's going to be typically 8-14. Might as well be seen in association with 2 and 8. Might as well be associated with other ones that you may mention, right? So this is going to be, yes, von Willebrand disease. Von Willebrand disease. That's an easy one, right? Yes. So those are the kind of questions which were considered as not so easy just about few years back. But with your continuous efforts, a lot of you will be able to pick up those questions in the exam. And my humble request is, that's the only thing that we have to do. That's the only thing which is present in our hands. Keep on revising to an extent where the not so easy questions also become cakewalk for you. That's the aim. Talking about the next important thing, that's going to be like systemic path. So hemat done. I think that's the shortest duration of hematology discussion I've ever done with anybody, right? GIT, easy one. Now you already know the diagnosis. So this is going to be intestinal columnar metaplasia. We are talking in terms of Barrett's esophagus. Detection with the help of a stain. Identify the stain that you see on the right side. Pretty good. Identify the stain on the right side. So that's going to be something that's going to be given the name of Alcian blue. Alcian blue, right? That is what you need to have an idea. Alcian blue is going to be helpful for detection of the presence of, yes, very good, acidic mucin. So we are talking about this patient in the longer run is going to be having a higher risk for development of something like the adenocarcinoma of the esophagus. That's an easy question. They're talking about the next one. Your patient was having the presence of a long-standing history of, let us say, adenomatous polyps. He was a smoker. He was an alcoholic as well. And let's say this guy was having the development of a weight loss. He was having the presence of flatulence and dyspepsia. Subsequently, what you had in this individual was having the appearance of a stomach like this, what is your diagnosis? So this is going to be a patient who's going to be suffering from stomach cancer, gastric cancer. Looking at the appearance of the left side, you're going to be having tumor cells which are going to be having the nuclei pushed towards the periphery. So that is going to be given the name of a signet ring appearance. Diffuse involvement of the stomach, that's going to be given the name of a leather bottle appearance of stomach. That's given the name of linitis plastica, is what I just wanted you to have an idea about. So the stomach walls are going to be dense fibrotic. What is this? What is this kind of a phenomena called as? Cancer cells are responsible for inducing dense fibrotic reaction in the associated areas. That is given the name of desmoplasia. So this kind of a phenomena is what is going to be given the name of desmoplasia. That's what you need to remember. Stomach cancer, pretty important in the sense that they will ask you about the location of the lymph node involvement in these patients. So left-sided supraclavicular lymph node involvement is given the name of a virtuous lymph node. You get involvement of the periumbilicus cutaneous metastatic deposits, that's given the name of Sister Mary Joseph nodule. Patients can be having involvement of pouch of Douglas. Per rectal examination, you're going to be having the presence of a bloomer shell. That is what you need to have an idea. So those are the important sites of metastasis that they love to ask in the exam time and again. Of course, you can talk about Lawrence classification. You can always talk about early gastric cancer causing involvement of the mucosa and the submucosa. Any cancer causing involvement of the muscle or it goes deep is an example of a late gastric cancer. So that's about the gastric cancer that you need to be familiar with. Of course, not forgetting standard microbiology question. Causative organism over here happens to be H. pylori. Now that's an example of a question which should be coming from your side. That's going to be easy. The mesenchymal tumor arising from the cells of Kajal. Mesenchymal tumor arising from the cells of Kajal. Guys, I wanted to answer this as well as I wanted to answer the second question which I already shared with you. H. pylori associated lymphoma is going to be associated with what type of tumor? Yes, very good. Very good. Talk about that. Mesenchymal tumor from the cells of Kajal. This is going to be given the name of the gastrointestinal stromal tumor. The gastrointestinal stromal tumor. So GIST tumor. When I'm talking about H. pylori associated lymphoma, the tumor that is going to be coming to my mind happens to be something that is given the name of a mole tumor. So those are the easy ones that they put up in the exam. Exactly the kind of question which has been asked in the exam multiple times. You had a patient who was, weaned off the breast milk and then this child was being given something to eat. The child was having a development of a diarrhea. The child became cranky. He was having weight loss. He was having the presence of a flatulence, or the child was not relishing the fact that he was being given the cereals. And on the intestinal biopsy, especially duodenal biopsy, you were having the flattening of the villi, and you were having the deepening of the crypts. So villus atrophy, deepening of the crypts, and you are having the presence of intraepithelial lymphocytosis. So we are talking about something that is going to be given the name of a celiac sprue. As and when we are making a mention of celiac sprue, we need to be familiar. Cereals to avoid. Hey bro, don't eat these cereals. Barley, rye, oat and wheat not to be taken by the patients. Barley, rye, oat and wheat not to be taken by the patients. Two types of complications which can be seen. Dermatological complications, very good. A lot of you know that. Dermatitis herpetiformis is what you need to remember over here. And please remember the fact that these patients are always at high risk for development of a cancer of the small bowel in the future. So that is going to be an example of a bowel T-cell lymphoma. Bowel T-cell lymphoma is going to be seen much more frequently in such patients who are going to be suffering from celiac sprue. Remember the fact celiac sprue is going to be associated with very few questions in the screening exam where they talk about the genetic association, but this is one of them. HLA DQ2, DQ8 is what is going to be extremely useful for having an established association with celiac sprue, right? That is what you need to remember. Talking about then a guy who's going to be having the development of initially the development of arthralgia or joint pain. He was then having the presence of abdominal pain and flatulence, and subsequently he developed neurological manifestation. The intestinal biopsy of this patient showed you presence of foamy macrophages, and this was also associated with the presence of infectious organisms. So what is the condition I'm talking about? If I'm talking about foamy macrophages over here, and there is an infectious organism, typically a bacteria or an actinomycete, this is going to be associated with classical involvement of what is associated with Whipple's disease. So involvement of joints, involvement of abdominal pain, and there is a presence of CNS manifestation. This is Whipple's disease, about which we need to have an idea because the causative organism over here happens to be Tropharema whippleri. Tropharema whippleri. Be familiar with the fact, if somebody was to ask you amongst all the causes of malabsorption disorders, whether I'm talking about celiac sprue, whether I'm talking about Whipple's, or I'm talking about something which is given the name of a tropical sprue, the commonest cause of malabsorption happens to be tropical sprue. Out of the three, in India, please remember the fact it is tropical sprue which is going to be a leading cause of development of malabsorption. Having said that, talking about these ones, recent exam questions full of the development of questions on polyps, particularly they ask you questions on hamartomatous polyps. So first example of a condition where they talk about a child who was having the presence of a rectal bleed, and this child was having he undergone a biopsy. The biopsy showed you presence of mucin-filled dilated cystic spaces. What we are talking about over here is an example of a polyp that's given the name of a juvenile polyp. Juvenile polyp. Child less than 5 years having a rectal bleed, having the presence of mucin-filled dilated cystic spaces. This is going to be juvenile polyp. In contrast, I'm talking about, let us say, a teenager, a pubertal age group individual who was having the presence of abdominal pain, because of which some investigation was being carried out and she was having the presence of smooth muscles, and these smooth muscles were having a Christmas tree pattern. They were having a Christmas tree pattern, or they were having an arborizing pattern. I mean, you just follow the smooth muscles over here. You would be getting beautiful designs over here. And that kind of a pattern is what is going to be given the name or associated with the polyp. This kind of a polyp is going to be given the name of Peutz-Jeghers polyp. So the first one is going to be a juvenile polyp, and the second one happens to be a Peutz-Jeghers polyp. That is what you need to have an idea. Single polyp is not troublesome at all. Single polyp is an example of a hamartomatous polyp. However, when multiple such polyps are present in case of an individual, you associate it with the term juvenile polyposis syndrome, or you associate with the term Peutz-Jeghers syndrome. And whenever you write the term syndrome over here, remember the fact that's where the trouble begins. So Peutz-Jeghers polyp and juvenile polyp per se are not bad. I mean, single polyp. But then if you're talking about juvenile polyposis syndrome, or you're talking about the Peutz-Jeghers syndrome, definitely they are associated with a high risk of development of cancer in the patients. Very, very high stuff that they put up to you in the exam. Now, I wanted to be familiar with identifying the syndrome. The patient was having the presence of a multiple Peutz-Jeghers polyps, along with the fact that this patient was also having the presence of perioral pigmentation. What's the syndrome? What's the syndrome? Multiple Peutz-Jeghers polyp and the presence of hypermelanotic involvement of the mucosal tissue, including the lips as well as at times the genitalia. This is going to be associated with Peutz-Jeghers syndrome. Of course, I can talk about a lot of other syndromes as well, but then what I was asked in the exam recently was about Cowden syndrome. Cowden syndrome is now a component of what is given the name of P10 hamartoma syndrome. So we are going to be having more syndromes as well as the BRR syndrome, the banana rival cabby relay syndrome. But then the point is, at least be familiar with the fact that P10 gene problem can be associated with Cowden syndrome, and we remember the fact these patients are at high risk for development of breast cancer. There is a high risk for development of endometrial cancer. There is a high risk for development of skin tumor, and the patients are at high risk for development of thyroid tumors as well. So I always told you the fact, the best of you will always remember it. The best of you will remember this information. So breast, endometrium, skin and thyroid, that's what you need to remember. Yes, Dr. Krishna, yes, remember that. I'm so happy for you. Yes, I told you only the best of you will remember. So you are definitely one of the best. So P10 is going to be associated with Cowden syndrome. That is what we need to have an idea. Talking about the next one, I mean, you are having hell large number of polyps over here, and the patient is going to be having a positive family history as well. So this is an example of a condition in which the patient is going to be having a positive family history. At the same time, the patient is going to be having 100 or more than 100 polyps. So this is going to be associated with the condition. That's what is being mentioned over here. That's going to be familial adenomatous polyposis. You're going to be the best, ma'am. Don't worry. Just have some faith in yourself and in your hard work, right? Familial adenomatous polyposis, and therefore this is going to be associated with a higher risk for development of colon cancer in the patients. Please remember the fact that a lot of these patients who are having FAP, they are going to be having the origin of the polyps by the time they are just about 15, 16 years of age. By the time they are 30, I mean, everybody is going to be having a development of polyp. By the time they are going to be 35, 40, a lot of them are going to be having a development of the cancer. So big time risk factor that we are having for such patients, and therefore if there is a patient of yours who is having a, I would say, a positive family history of FAP, then these patients are advised to undergo prophylactic colectomy, right? So that is what you need to remember. So that cutoff number is very important. FAP plus development of CNS tumors is what is going to be associated with Turcot syndrome. FAP plus osteoma plus presence of multiple other tumors, fibromas, osteomas or cystic lesions, that's going to be associated with Gardner syndrome. That's what we need to have an idea. Which will also remind us of the fact that if we are talking about FAP, patients are in the future at high risk for development of colon cancer. Most common site for the colon cancer happens to be the rectum, and the commonest presentation of a patient having rectal carcinoma happens to be the bleeding per rectum. The bleeding per rectum, that is what we need to have an idea, right? No question in the exam is ever going to be complete without having a discussion of what is given the name of an apple core appearance. Standard radiology question. That's the tumor. That's the tumor causing impingement of the lumen, and once the lumen is going to become narrow, you are going to be having an appearance of the patient is going to be having an apple core appearance. What you need to just remember and revise for me, if I'm suspecting a patient to be suffering from colon cancer, what is the best tumor marker I would be looking out for in order to observe the response of therapy to my patient? What's the tumor marker I should be looking out for for observing us. Okay. Yes, absolutely, Dr. Deshra. Can I just get to know what is an example of a tumor marker which is going to be useful for monitoring the response of therapy in the patient? It's going to be something like, yes, very good, carcinoembryonic antigen. That is what we needed to have an idea, right? So that's going to be an easy one again. I mean, let us not make a goof up on that kind of a question. Apple core appearance. I mean, with colon cancer, you remember it with a patient who's going to be having the presence of an apple core appearance, right? Next thing we talk about lungs, and a standard easy question that they put up to you in the exam. Typical pneumonia, that's going to be bacterial pneumonia, also given the name of air stress pneumonia, characterized by the hallmark finding. Can you just identify this hallmark finding? Even if you don't get anything with respect to the histological feature over here, at least you should be able to make out the fact in the alveoli you are having the presence of exudate. Alveoli you are going to be having the presence of exudate. That is what you need to have an idea. So in context of the alveoli, you are going to be having the presence of an exudative fluid over here. So there is presence of alveolar exudate. That's what I just wanted to be familiar with over here. So you don't need to worry on that particular account. Also be familiar with the fact that if I'm talking about atypical pneumonia, what you are having over here in atypical pneumonia is interstitial tissue inflammation. So air space pneumonia characterized by presence of alveolar exudate. Interstitial tissue inflammation is a feature of atypical pneumonia. Commonest cause of atypical pneumonia is mycoplasma. Typical pneumonia, of course, you can talk about Staph aureus, strep pneumonia, pseudomonas, depending upon the different kind of conditions that I did make a mention of with you earlier, right? Having said that, talking about the different kinds of pneumoconiosis, and pneumoconiosis again a kind of question that they put up to in the exam quite frequently. As and when we are making a mention of something like pneumoconiosis, you just remember the fact patients could be having the commonest pneumoconiosis, having a radiological appearance like this. That's given the name of eggshell calcification. So can I just get to know what is going to be the pneumoconiosis we are talking about over here? So the pneumoconiosis that we're going to be talking about over here is going to be given the name of silicosis. Okay. So silicosis is going to be the commonest example of pneumoconiosis. You're going to be having an individual who's going to be suffering from, who's going to be working in the sand mine or Blasters disease. That's what they typically give you as a question in the exam. If you're talking about this kind of a pneumoconiosis, let's say my patient was having a pulmonary fibrosis. I took the lung biopsy, and what I found in my patient was this kind of a structure. These kind of structures. So that is suggestive of, very good, asbestos particle. So I mean, these are two different images. That's why there was a line that I had drawn. On the left side you were having eggshell calcification, that is suggestive of silicosis. On the right side I'm talking about something which is going to be having an asbestos body. And when I'm talking about an asbestos body, this is going to be associated with the trouble that the patients are going to be having the development of a dumbbell shaped body. That's going to be given the name of an asbestos body. If it is going to be having an iron proteinaceous covering, that's also been given the name of a ferruginous body. So ferruginous body or asbestosis or asbestos body is what you find in a patient who's going to be suffering from asbestosis. That is what I want to be aware of over here. That's going to be easy. The question in the exam can be that this guy, let us say, is going to be working as a farmer, and then this guy is going to be having inhalation of sugarcane dust. That obviously is going to be bagasosis. The question can talk about a textile worker. He's going to be having bisonosis. That's another thing that we need to remember. Identifying the picture of the lung over here. Easy question. You're most welcome, Dr. Hitesh Pramod जी. प्रणाम, कैसे हैं आप? मैं उम्मीद करता हूँ अच्छे हैं. इसको फटाफट रिवाइज कर लेना यार. इसमें से मतलब ऐसी इन्फॉर्मेशन है जो कि मस्ट नो इन्फॉर्मेशन है. ऐसा कुछ भी नहीं है जो आपको नहीं आना चाहिए था. So all that information is pretty useful for you. And then when I'm talking about something of this sort, what I'm going to be getting is a black color of the lung. And therefore what I'm talking about over here is black lung. Inhalation of coal dust is what is going to be associated with black lung. Anthracosis. If you remember the fact, in fact, any kind of inhalation of coal or carbon particle, for that matter, I would use the word carbon particle, because carbon particle can be coming from coal. Carbon particle can also be coming from air pollution. So if you are residing in a big metropolitan city, I mean, one of the flip side is that you are having an inhalation of air which is a bad quality air, and therefore we are going to be having deposition of a black colored pigment over here, and that is what is going to be associated with development of anthracosis. I hope that is something which is going to be associated with the term anthracosis, which is going to be picked up by you, right? So that is what is easy for you to be familiar with. Of course, in the longer run, patients can have a development of a complication that is given the name of progressive massive fibrosis, right? Talking then about an example of an obstructive lung disorder, this one is going to be easy because the patients are going to be giving you a history of cigarette smoking, and when the patient is going to be having a history of smoking, he is going to be having a predominant involvement of upper lobes of the lung. So that's going to be easy because this patient is going to be having a development of what is given the name of centri acinar emphysema. I want you to remember and recall quickly. If a patient is going to be having alpha-1 antitrypsin deficiency, then these guys are going to be having a development of pan-acinar emphysema, typically causing involvement of base of the lung, right? Patients having emphysema, the clinical presentation of the patient is in the form of dyspnea, and these patients are going to be having very typically the development of weight loss. Having a discussion about where do we use the term Reed's index. This is going to be associated with a patient who is going to be suffering from chronic bronchitis. Clinical definition, productive cough for at least 3 months in 2 consecutive years, right? We are going to be calculating Reed's index because you're calculating the thickness of the mucous gland layer in the numerator divided by the distance between epithelium and cartilage. So that is given the name of Reed's index. Increased index, I repeat, is a feature associated with chronic bronchitis. I want to remember and answer these questions. Can you give me an answer for the question which I'm labeling as 1? And what's your answer for the airway disorder which is going to be associated with 2? So which particular condition is it going to be associated with the fact that the patient is going to be having airway remodeling? Just answer that, guys, for 1 and for 2. Answer that simultaneously. Disorder 1, disorder 2. Disorder 1, disorder 2. Can you just let me know that? Can you please let me know that? That's going to be a fairly easy thing for most of you to pick up. Airway remodeling is a feature that you associate in a patient who's going to be having bronchospasm. This patient is going to be having type 1 hypersensitivity reaction. There is going to be IgE antibody on the mast cell degranulation, salbutamol, terbutaline, salmeterol, inhalational budesonide, presence of Montelukast. Yes, we are talking about a condition that's given the name of bronchial asthma. If I'm talking about abnormal permanent airway dilatation, this is going to be seen in a patient who's going to be suffering from bronchiectasis. I'm just so happy. Jitendra Pramar, Alok Anand, Srishti, Hitesh Singh, Akhil, Neha, very good. So this one is going to be, the second one is going to be bronchiectasis. The first one is going to be bronchial asthma. Yes, Dr. Neha. Yeah, Nehal. Yes, Dr. Shagun. Yes, Dr. Neha. Yes, Dr. Krishna Padai. Yes, Doctor. Okay. So those are going to be easy ones. I mean, right? How to make a diagnosis of obstructive lung disorder? Spirometry. If I'm talking about lung cancer, so very commonly asked question in the exam. Guy is a smoker. This guy is going to be having exposure to air pollution. This guy is going to be having a history of exposure to radon. Or this guy is going to be having genetic mutations, P53 mutation. Or he's going to be having the presence of certain types of exposure, say for example radiation. Then this patient is going to be having a development of lung cancer. So this patient is going to be having cough, weight loss, hemoptysis. He could be having a compression of the neural structures as well. So Pan-Cos tumor can be seen, Horner syndrome can be seen, superior vena cava syndrome can be seen in the patients, right? If I'm talking about cavitation, increased calcium and keratin, very suggestive of squamous cell cancer. All the 3 questions have been asked in the exam separately. You have a patient who's going to be having a peripheral cancer. The patient is going to be having a clubbin. This is going to be seen in case of females and this is going to be seen in case of non-smokers. We are talking about adenocarcinoma of the lung. So cavitation, hypercalcemia, presence of keratin, squamous cell carcinoma. Peripheral cancer associated with clubbing, associated with the presence of a cancer in the non-smokers as well as in case of females, adenocarcinoma. Small size tumor cells, neuroendocrine origin, maximum paraneoplastic syndrome, presence of neurosecretory granules on the electron microscopy. What is the cancer that we are dealing with? Yes, we are dealing with small cell cancer. The point is, we watch out for the video. You make the table in your own handwriting wherein you know about the specific features associated with specific subtypes of lung cancer. That's the aim. So the purpose of knowing about this information is that you have an idea about the most important features associated with the specific types of the variants of the lung cancer. That's what I wanted to be aware of over here. Having said that, that's going to be easy one. Last to last exam, they ask you a question. Popcorn calcification, we are going to be having popcorn calcification is going to be associated with a tumor which is going to be an example of a hamartoma, and this kind of hamartoma is going to be seen in the lungs. So that's an example of pulmonary hamartoma. So pulmonary hamartoma is going to be associated with the popcorn calcification. That's an easy question. That is what we need to be aware of over here. I hope you're getting it right. So that's going to be a quick one over here. Alright, that's what we need to remember over here. Now talking about the cardiovascular system, easy but important topic for our exams, and we can just quickly go through rap zoom with cardiovascular system, and that's the patient who's coming to you because he's having the presence of a localized headache, he's having jaw claudication, he's having the presence of a shoulder and the pelvic girdle pain. Yes, we are talking about a patient having, you're very right, giant cell arteritis. It's an example of a large vessel vasculitis, giant cell arteritis. Patients are going to be having the presence of a prominent and a patchy involvement of the superficial temporal artery. So this patient is going to be having a giant cell arteritis. Microscopic appearance of giant cell arteritis, the guy is going to be having the presentation in the form of development of giant cells. There is a granulomatous inflammation So you do have the presence of giant cells over here, and the lumen is going to get compromised, which is responsible for giving the clinical symptoms in the patient. The commonest reason why we need to be familiar with this kind of a trouble is it's very prevalent in 50 plus years of age of a patient. And fact number 2, this patient can be having an ocular complication. This patient can be having a development of sudden onset of blindness. Now, because the patients are going to be having a sudden onset of blindness, so this can be a troublesome thing for the patient, and therefore, in the shortest of the clinical suspicions in your patient, give this individual, save his vision, give this patient a drug that's going to be IV methylprednisolone, right? Talking about the next one, patient is going to be having an involvement of aortic arch, that's given the name of aortic arch syndrome, also given the other important and fascinating name of Takayasu arthritis, also given the third important name of pulseless disease. Again, an example of a large vessel vasculitis. The differentiation feature is it is seen in younger patients. So Takayasu is going to be seen in younger individuals. That's an important thing that you need to remember from the exam's perspective. Of course, you are going to be having the involvement of the aortic arch. You can also have involvement of the subclavian vessel as well. And therefore, clinically, this patient can be having a differential blood pressure in the two different arms. I mean, that can be another important thing that can be given to you in the exam question. So this is what is going to be associated with Takayasu arthritis. That is what we need to have an idea. Talking about polyarthritis nodosa, very, very commonly asked question. Hepatitis B is what you need to remember. Fibrinoid necrosis, type 3 hypersensitivity reaction, polyarthritis nodosa, lungs are spared. Remember the fact, lungs are spared. I told you so many times, pulmonary vessels are not involved. Polyarthritis nodosa, kidneys can be involved in these patients, that is for sure, but you cannot have glomerulonephritis. Patients having polyarthritis nodosa are going to be having the presence of a inflammation in which all the stages of inflammation can coexist in the same vessel. So you can have acute inflammation, you can have chronic inflammation, you can have I would say a stage of healing, which can be coexisting in the same vessel in the patient. That is about polyarthritis nodosa that we need to remember. So that's going to be seen typically in case of young individuals, right? We are talking about a child. The child is going to be having the presence of mucosal involvement. This child was also having the presence of conjunctivitis. The child was also having the presence of the edema of hands and feet. He was having the development of cervical lymphadenopathy, and the patient is going to be having the development of a coronary angiography, which is going to be showing you the presence of what is given the name of Kawasaki's disease. So Kawasaki's disease is going to be a troublesome disease for the child for the simple reason it can be responsible for causing heart attack in the child, myocardial infarction in the child. Yes, you know that particular fact. This kind of an appearance of patient having Kawasaki's, this can be associated with the development of what is given the name of strawberry tongue. Strawberry tongue. I just want you to recall what is going to be an example of a condition which is going to be responsible for causing the development of strawberry gums. Strawberry gums is a finding of, strawberry gums is going to be seen with, yes, I wanted to answer that correctly, guys. This is strawberry tongue. Strawberry gums is a finding of, yes, you know that fact. This is going to be associated with GPA, granulomatosis with polyangiitis, which was earlier given the name of vaginous granulomatosis, right? That's what you need to remember over here. Now, that's an example of a young male smoker coming to you because he's having the presence of trouble at the time of walking, or he's going to be having a development of Raynaud's phenomena in his fingers. As you can find over here, he has developed digital ulcers over here. If not precautions are being taken, then there can be a development of gangrene as well. And this is going to be associated with the development of obliteration of the lumen over here because of a thrombus or a microabscess. So this is the patient suffering from thromboangiitis obliterans. Thromboangiitis obliterans, also being given the other important name of Berger's disease. Thromboangiitis obliterans, Berger's disease. Last to last exams question. My simple point is that you should be these days not only be familiar with the diagnosis of the conditions, but then instead of asking you a question, let us say if I were to ask you that what is the most common risk factor for Berger's disease, your answer would have been straightforward, smoking. But you also need to remember nowadays that clinical presentation is what is going to be the key thing, and almost every video of ours, if you see the 2023 videos, are going to be having a small description of the clinical history in the patient. Then we talk about what exactly would you expect to find in the patient, and then we talk about the histological findings that are going to be seen in the patient, right? That's what you need to have an idea. Talking about then ANCA, anti-neutrophilic cytoplasmic antibodies. So we're going to be having two types of ANCA. One which is going to be given the name of PR3 ANCA, that is also given the name of C ANCA. And then we are talking about something which is going to be given the name of MPO ANCA. MPO ANCA also given the name of P ANCA, the earlier name. So MPO ANCA, the antigen over here is myeloperoxidase. C ANCA, the antigen over here is PR3 ANCA. That is what we need to remember. If you are talking about PR3 ANCA, example of the only condition which is going to be having this is granulomatosis with polyangiitis, earlier called by the name of vaginous. And when I'm talking about something which is going to be given the name of MPU anchor, you can be having a lot of conditions where you have this microscopic polyangiitis. You can be seeing it in a patient suffering from EGPA, or you can be associating it. EGPA is eosinophilic granulomatosis polyangiitis, earlier called as Sparsh syndrome. So the only reason of talking about these particular facts is that we need to be familiar with the new names as well. New names of the antibodies as well as the new names of the disorders. So vaginous now is being given the name of GPA. Sparsh is being given the name of EGPA, right? That is what we need to remember. Otherwise, things are going to be easy because these are the example of antibodies which is going to be useful for making a diagnosis of certain types of vasculitis. Now, the important example of a vasculitis most often asked in exam is GPA. And when I say GPA, that means granulomatosis with polyangiitis. So granulomatosis with polyangiitis would be characterized by the fact patients are going to be having, as I always told you, rule to remember, renal involvement, necrotizing granulomas can be seen in multiple organs of the body, especially upper respiratory tract, in the lungs, and in the kidneys. The patients are going to be having a development of a focal or a crescentic glomerulonephritis. Because of involvement of the lungs, patients can have cavitary pneumonias. Remember the key word over here, cavitary pneumonias. And the patients are going to be having fever, they're going to be having cough, they can be having hemoptysis, and the patients are going to be having the presence of strawberry gums. What do you find in a patient having granulomatosis with polyangiitis? These patients are going to be having what type of an antibody? They would be having the presence of PR3 anchor. So they would be having PR3 anchor. That is what we need to remember. What will cause the death of this patient? It is not the cavity in the lung which is causing death of the patient. It is typically the patients are going to die because they are going to be having a development of crescentic glomerulonephritis. So they will die because of renal dysfunction or renal failure. Last exams question. Hinox-Schönlein purpura, nowadays given the name of IgA vasculitis. Patients typically are going to be having the development of a rash. What kind of a rash? Extensor surface rash. What is the reason for the rash? Vasculitis, small vessel vasculitis. What is the pathogenic antibody? IgA is the antibody involved. Apart from the rash, patients can have involvement of the GI tract, abdominal pain. Patients can also have involvement of the joints. Patient can also have involvement of the kidneys. So it is involvement of skin. It's the involvement of GI tract. There is going to be involvement of joints, and the patients are going to be having the involvement of the kidney as well. The diff means direct immunofluorescence. That's a derma question typically. The diff of these patients is going to be showing you the presence of antibody, IgA antibodies at the level of the dermal papillae. So that is what is going to be associated with Hinox-Schönlein purpura, IgA vasculitis. What example of hypersensitivity? This is an example of, can you just answer for me guys? This condition, IgA vasculitis, is an example of which type of a hypersensitivity reaction? That's not going to be very difficult for any of you. Yeah, I know we have been going around for a good 2 hours 25 minutes, but then you know the fact is really easy. This is going to be an example of a type 3 hypersensitivity reaction. That's an example of a type 3 hypersensitivity reaction. Having said that, talking about myocardial infarction, this is going to be triphenyl tetrazoline chloride. What is the enzyme that it reacts with? It reacts with LDH. Normal tissues contain LDH. Triphenyl tetrazoline chloride is therefore giving you a brick red color. Infarcted area, there is a damage. Enzyme leaks out. So the enzyme leaks out, you're going to be having a pale area. What's the concept of flipping? The concept of flipping is simple. In a normal individual, you take the blood sample, LDH2 is more than LDH1. In case of a patient having heart attack, LDH1 is more than LDH2. So if you see this, there is a reversal of the ratio that you have in the patient. So that is what is given the name of flipping concept. Flipping of LDH ratio is a feature associated with myocardial infarction. If I want to make a diagnosis of myocardial infarction, what is the most sensitive and the most specific enzyme? Yes, very good. Cardiac troponins. Cardiac troponins, right? That is what you just need to be familiar with over here. Having said that, microscopic features are sometimes asked in an exam. Earliest feature usually happens to be the wavy fibers. Typically, in the first 72 hours, you are going to be having neutrophilic infiltration. So that is going to be the example of a normal area. The necrosed area is going to be hypereosinophilic, and you're going to be having the presence of neutrophilic infiltration. Beyond 72 hours, you would be having the presence of a lot of macrophages over here. Subsequently, you're going to be having the presence of granulation tissue over here, and then there is going to be replacement by the fibrotic scar. So simple thing, less than 3 days, neutrophilic infiltration, more than 3 days, macrophages. Subsequently, you're going to be having beyond 7 days, you're going to be having a lot of granulation tissue, and beyond couple of months, you're going to be having a fibrotic scar. That's easy. Reperfusion injury. Patient is having a heart attack. He's brought to the hospital. The doctor gave him streptokinase, but the condition of the patient worsened. The patient died. On his autopsy, we found that there was presence of what is given the name of hypereosinophilic contraction bands. I hope you can make them out. contraction bands. Can you just make that out? Those bands, hyper-eosinophilic contraction bands, and those hyper-eosinophilic contraction bands is what is very much suggestive of reperfusion injury. What's the reason for the reperfusion injury? The reason for the reperfusion injury is the free radicals coming in because of the thrombolysis. So a lot of blood comes in, gush of blood, because of which the lot of free radicals are coming in, and that is what is going to be responsible for causing reperfusion injury. That's the only thing that we need to have a revision. RHD, standard question in the exam, identify the structure. Last 3 years, 4 questions on this kind of a structure, that is Ashaw's body. So you're going to be having the presence of fibrinoid necrosis in the center. You got plump macrophages over here, which are going to be given the name of the caterpillar cells or the NHCO cells, and you're going to be having the presence of the macrophages over here. So you're going to be having the presence of fibrinoid necrosis, plump macrophages, and lymphocytes. That's going to be given the name of Ashaw's body, seen as a feature of rheumatic heart disease. Rheumatic heart disease, classical thing. What is the commonest age group affected? Excuse me. Age group affected in the patients, typically a disease of children, 5 to 15 years. What is going to be the hypersensitivity reaction? That's type 2 hypersensitivity. Pericardium involvement can be seen, myocardium involvement can be seen, endocardium involvement can be seen. Pericardium involvement, bread and butter pericarditis. You're going to be having myocardial involvement. Patients are at high risk for development of cardiac failure because of the myocardial inflammation. If you're going to be talking about myocarditis around the blood vessels, you are going to be having the presence of Ashaw's body. So that's easy. Endocardium involvement, you get typically the involvement of mitral valve. Acute, you get involvement of mitral regurgitation. Chronic, you have a development of mitral stenosis. Mitral regurgitation associated with the development of lesions in the left atrium, McCallum plaque. Mitral stenosis, you have a narrowing of the lumen of the mitral valve. So therefore the patients are going to be having mitral stenosis. This is what is going to be associated with the term fish mouth stenosis, also given the name of buttonhole stenosis. All questions which have been asked in the exam, directly or indirectly. What is the reason for the development of mitral stenosis? Reason for mitral stenosis, all India exam question, fibrosis and the deposition of calcium. So calcium deposition and fibrous tissue deposition is what is going to be responsible for causing mitral valve stenosis. All the 3 layers of the heart are involved, so this is going to be associated with the term that is going to be pancarditis. If a patient is going to be having the development of endocardium, mitral valve, he is going to be having the presence of vegetations. Where are the vegetations present? Line of closure. Do they have bacteria? No. So they are small. They have no bacteria, so they are sterile. And please remember that they are not going to be associated with embolization. Why? Because they are very firm. Small, sterile, firm vegetations present along line of closure. Typical feature of vegetations associated with rheumatic fever. That's what we need to have an idea. Quick revision. That's the other thing that we need to remember. So rheumatic heart disease, done and dusted. Infective endocarditis. Large vegetations. These vegetations are going to be containing bacteria. They secrete enzymes, so they can have a complication, ring abscess. They can also be responsible for causing a development of a high risk of embolization, maximum risk of embolization, infective endocarditis. Staph aureus, Streptococcus viridans. Liebman sac endocarditis, you see that in a patient suffering from SLE. Non-bacterial thrombotic endocarditis, hypercoagulable state, carcinoma, pancreas. Patients who are going to be having mucin secreting tumors, say for example, acute promyelocytic leukemia. So that is what is going to be associated with non-bacterial thrombotic endocarditis. In case of Liebman sac endocarditis, you can get involvement of both the valvular surface, but predominantly it is a lower surface which is affected. Liebman sac endocarditis, lower surface is affected more, right? That is what is asked in the exam. Identify the tumor. Patient was having a tumor. This was having the presentation in the form of fever, malaise. The doctor, the cardiologist did the auscultation of the patient and he was having the presence of a tumor plop. Tumor plop, this is the tumor. So we are talking about a tumor that is going to be given the name of a myxoma. Myxoma, site of origin, left atrium. This is typically going to be having an origin from which part of the left atrium? Can somebody answer that for me? That's going to be an easy question. What is the specific site of origin of a myxoma? Atrial myxoma, very good, left atrium, but what is the specific site of origin? Can anybody let me know the answer? Yes, Dr. Jitendra, Dr. Digambar, Dr. Kishore, Dr. Isha, Dr. Medico, Dr. Neha. Yes, that is going to be fossa ovalis. Fossa ovalis, that is what I wanted to be familiar with. Any patient who is going to be having this kind of a tumor, microscopically you are going to be having what kind of a cell? You are going to be having the presence of lipidic cells. That's what we need to remember. Typically, cardiac tumor that you see in case of children, that is rhabdomyoma. Rhabdomyoma having what kind of cells? It is going to be having the presence of spider cells. So you are having glycogen containing cells, glycogen gets washed off, you have this appearance of the cells, rhabdomyoma. So myxoma, adults, rhabdomyoma, children. That is what is going to be remembered by you. Quickly, we brush up kidneys. When you talk about glomerulonephritis, the type of glomerulonephritis that is seen most commonly in case of children. In case of children, it is going to be post-streptococcal glomerulonephritis. Kidney biopsy showing me what kind of an appearance? Starry sky appearance. Starry sky appearance in the kidney biopsy. If I'm talking about Buerger's disease, BD, big people's disease, Buerger's disease, most common cause of glomerulonephritis in case of adults. What is the antibody involved? IgA antibody. Therefore, it is given the name of IgA nephropathy. Alright. If I'm talking about RPGN, big time problem. Patients are going to be having crescent formation. Because of crescent formation, kidney function is going to get compromised. So patients die because of development of renal failure. That is about glomerulonephritis. What kind of urinary cast do we have in glomerulonephritis? Patients are going to be having the presence of RBC cast. That is what is known to me. So patients would be having the passage of cola colored urine, especially a child after suffering from a sore throat or a pharyngitis. That would be after 10 to 14 days. Young adult having a development of cola colored urine within 3 days of suffering from sore throat, that is Buerger's. Known patient of kidney disease suddenly has got increase in blood urea nitrogen or sudden increase in serum creatinine over a period of last few days. My patient is going in for RPGN. If I'm talking about this appearance, hemorrhagic spots on the surface of kidney. What is this appearance known as? Yes, insects are biting the kidney. So that's given the name of flea-bitten kidney. Flea-bitten kidney. You can have it in a patient suffering from vasculitis, leukemias, lymphomas. Patients could be having it in a patient having RPGN. You have it in a patient having malignant hypertension. But the fact is, you need to be remembering about this kind of an image, flea-bitten kidney. Nephrotic syndrome, minimal chain disease. Commonest cause of nephrotic syndrome in case of children. Membranous glomerulopathy. Commonest cause of nephrotic syndrome you have in case of adults. FSGS. Commonest cause of nephrotic syndrome that you have in case of adults. Elderly people, membranous, adults, FSGS. MPGN. Multiple variants, but then you associate with the term dense deposit disease. Systemic disorders. Systemic disorders, some kind of a malfunction does take place at the level of the iPad as well. Systemic disorders. Most common systemic disorder causing nephrotic syndrome, diabetes mellitus. Other conditions which can be causing systemic disorders and nephrotic syndrome, amyloidosis, SLE. So quick fact that you need to remember. Amongst these, the important exam-based image questions can be minimal chain disease. What do I find in the minimal chain disease? The best way of making a diagnosis is electron microscopic examination. What do I look at? Kidney biopsy. What does it show me? Normal kidney has podocytes. This kidney is having damage to the foot process of podocytes, effacement of the podocyte. That is what is said in case of minimal chain disease. How do I treat it? Give steroids. Most of the patients would respond well. Membranous glomerulopathy, elderly patients who are going to be having solid cancers, they are going to be having granular immunofluorescence. Granular immunofluorescence. You see the appearance of the immunofluorescence section of the renal biopsy, granular immunofluorescence. Patients can also be having special staining. With the help of silver stain, you are going to be getting an appearance. What was asked to you in the exam, in the NEET PG exam as well, spike and dome appearance. Spike and dome appearance. So spiky appearance, can you just make that out? That hair-like appearance, hair-like appearance, hair-like appearance, spiky appearance, hair-like appearance that you get in the kidney biopsy, feature of membranous glomerulopathy. So that is what you need to remember over here. Quick revision. Vascular disorders, two types of conditions. One, benign nephrosclerosis, elderly people, benign hypertension, aging, appearance of the kidney, leather grain kidney. Second one, malignant nephrosclerosis, kidneys involved, malignant hypertension. What is the appearance of the blood vessel? Concentric ring of smooth muscle cells. So that's given the name of onion skin appearance of the blood vessels. What's the condition that you associate over here? These patients are going to be having malignant nephrosclerosis and they would be having flea-bitten kidney. So absolutely rapid fire that we are having over here. RCC, renal cell carcinoma. Commonest malignant tumor that you have in case of adults. Problem with the tumor, it is polar. It is going to be associated with multiple types of risk factor. What is the number one risk factor? Tobacco exposure. Can be associated with estrogen, can be associated with petroleum, asbestos, can be associated with sickle cell trait, certain types of syndromes, all that we have discussed about earlier. But then risk factor number one, that's going to be tobacco use. Commonest type of renal cell carcinoma, clear cell cancer. You associated with patients who are going to be having what type of syndrome? VHL syndrome. Tumor cells are going to be having a loss of glycogen and fat. So they appear empty, they appear clear to you, right? Arising from proximal tubular cells. they are going to be typically unifocal, right? If I'm talking about the other important examples, I mean the other important example can include the type of kidney cancer which is going to be having the presence of psammoma body. Remember, psammoma body is going to be typically seen in association with papillary cancers. Which type of kidney cancer is going to be having the best prognosis? Chromophobe. Which one is going to be having the worst prognosis? It is going to be Bellini duct. Elderly patient having kidney cancer, what can be an atypical presentation? I mean, question, E. coli, Proteus. What is the microscopic structure that you have in these patients? Michaelis Guttman body. Michaelis Guttman body. That's the only thing that I'll have to ask in the exam. So M for Malakoplakia, M for member, Michaelis Guttman body. Please be familiar with the fact. You're talking about urinary bladder cancer. What is the type of cancer that you see in the patients? Most commonly, transitional cell carcinoma. What is the number one risk factor? Patients who are going to be having a history of smoking or the patients who are going to be having a history of tobacco use. You can also be having the development of different other types of urinary bladder cancer. Say for example, the patient could be having the presence of something that is given the name of a squamous cell cancer. That would be seen in a patient who is going to be having the presence of stones. So urinary bladder stones, if they are present, or if I ask you the micro question, example of a parasitic infection which can increase the risk of urinary bladder cancer, that is going to be schistosomiasis. So schistosomiasis associated with urinary bladder cancer. That is what you need to remember. What is the clinical presentation? This patient is going to be having painless hematuria. What was the question given to you in the exam? So there was an elderly individual in whom they had performed a prostatectomy. Along with that, they had to take out the bladder as well. Why? Because the bladder was also involved. The bladder was having the cancer. So cystoprostatectomy was done in the patient, and that was a kind of a similar appearing image was given to you in the exam. So when you look at the image, there is a presence of abnormal growth over here. That is suggestive of a cancer. That is what is going to be useful for making a diagnosis. Having said that, different casts. I mean, these are one-liners. Quickly, these are all examples of pathological cast. Only physiological cast. January 2023 question, Tam Horsfall, and that's going to be an example of a Hyaline cast. RBC cast, glomerulonephritis. WBC cast, pyelonephritis. Lipid cast, oval fat bodies, nephrotic syndrome. Dirty brown cast or muddy colored cast, that is acute kidney injury. Broad waxy cast, that is chronic renal failure, right? So that is what we just need to be familiar with over here. Dr. Akhil, if you have something better to do, my friend, just utilize your time, invest your time elsewhere. If you think that this kind of a rapid discussion is useful for you, then obviously you will just stay around for some more time. Hopefully we just try to wrap it up as at the earliest, right? So those are the different types of cast. If you talk about endocrinology, you just need to remember about two disorders very commonly, thyroid, and you need to remember about diabetes. So when I talk about a patient who's going to be having Graves' disease, what my patient is going to be having is presence of those papillary projections. And these papillae are going to be consisting of hyperfunctional cells. So they are going to be having the presence of what? They're going to be having the presence of that whitish color area that is called as scalloping of colloid. So Graves' disease patients, T3, T4 is going to be elevated. Patients are going to be having, because the feedback inhibition, TSH is down, my patient is going to be having a development of heat intolerance, and on the microscopic examination he is going to be having the presence of papillae structures along with scalloping of the colloid. That is what I want you to remember. So female patient, weight loss, polyphagia, palpitations, heat intolerance. T3, T4 is more reduced TSH. That is a kind of question that they gave in the exam, couple of exams back. For those of you who are still practicing the clinical questions, and I hope, within the next few days, we are going to be uploading an absolutely brilliant Q bank dedicated for you. You're going to be appreciating how the effort has gone in making that kind of a Q bank. So this is suggestive of a patient having hyperthyroidism, and the commonest cause of hyperthyroidism happens to be Graves' disease. In complete contrast, female patient, I would say 40 to 50 year old female, she is feeling lethargic, she's having anemia, she's having menorrhagia, and she's having cold intolerance. And when I get the thyroid function test done in her, she is having the presence of decreased T3, T4, and she is having elevated TSH, suggestive of hypothyroidism. And one of the commonest causes of hypothyroidism happens to be Hashimoto's thyroiditis. What is the antibody expected to be seen in these patients? Yes, that is going to be anti-TPU antibodies, right? Papillary thyroid cancer, all-time favorite amongst all the thyroid cancers. That's the most popular type of thyroid cancer associated with radiation exposure. Young patients typically. Patients are going to be having the presence of papillae-like structures. But more important than the papillae, it is the nuclear findings. And I repeat that for the nth time. It is the nuclear finding that is going to be diagnostic of these patients. And these nuclear findings are going to be including the presence of nuclear grooving, the presence of pseudonuclear inclusions, and the appearance of nuclei, which are going to be appearing to you optically clear nuclei. That's going to be given the name of orphan NEI nuclei. Orphan NEI nuclei. That's exactly the question that they put up to in the exam at least 3 times earlier. So a very basic kind of a question. Which type of thyroid cancer would you associate with amyloid deposition? Can those of you who are watching the video now answer that question for me very quickly? Example of a thyroid cancer that you associate with something like amyloid deposition. Yes, we did make a mention of that earlier. Amyloid deposition is a feature of which particular type of a thyroid cancer? Amyloid deposition is something that you associate with medullary thyroid cancer. Remember that fact, right? We have an example of a thyroid cancer that cannot be differentiated on the basis of the fine needle aspiration cytology. Fine needle aspiration cytology cannot distinguish between a benign follicular adenoma and a follicular carcinoma is the third thing that they have to ask you in the exam, right? So that is what you need to be familiar with so far as the papillary thyroid cancer is concerned. Of course, that's an example of a giveaway kind of a question. Patient having uncontrolled diabetes for the last 8 to 10 years, he experiences that he is going to be, he undergoes a routine test, and then he was having the presence of, I would say, subnephrotic proteinuria. Kidney biopsy was taken from this patient and it was having the presence of such lesions. What is the characteristic finding that you have in this patient? That's what is going to be associated with nodular glomerulosclerosis, also given the name of the most characteristic lesion of kidney involvement in diabetes, and that's given the name of the Kimmelstein-Wilson lesion, right? The earliest lesion that can be picked up in the kidney biopsy, however, is going to be the basement membrane thickening. The lesion that is going to be most commonly associated with the development of a CKD kind of a condition is going to be diffuse glomerulosclerosis, but this kind of a lesion is going to be important because this lesion also correlates pretty commonly with the increased risk or development of the retinal complication in the patient as well. So diabetic retinopathy correlates with the development of the Kimmelstein-Wilson lesion, and that is going to be a finding that you associate with a patient who's going to be having uncontrolled diabetes for quite some time. That's what we need to remember, of course, right? Talking then about the hepatobiliary system, easy questions asked in the exam. They will, usually in the clinical practice, we encounter the patients who are going to be having jaundice. So we talk about, either we are talking about something like hemolytic anemias, or we talk about the children who are going to be having a physiological jaundice, or we talk about the pathological conditions where there is a biliary tract stone, or there can be a cancer, or there can be troubles like sclerosing cholangitis and stuff. But quite commonly in your exam, they would be asking you questions associated with unconjugated as well as conjugated hyperbilirubinemia. So unconjugated hyperbilirubinemia associated with conditions like Gilbert syndrome and Crigler-Najjar syndrome. Gilbert syndrome is typically going to be an adult patient who is going to be asymptomatic. Incidentally, he is having an unconjugated hyperbilirubinemia, especially after some kind of a stress or fasting. That is exactly the question they gave you 3 exams back. Crigler-Najjar is a problem that we see in case of neonates or in case of children because of decreased activity or sometimes even absent activity of the enzyme, the UDP glucuronide transferase. So both these conditions, remember the fact, are having unconjugated hyperbilirubinemia. If you are going to be having a trouble at the level of secretion of the conjugated bilirubin, this can either be an example of a Dubin-Johnson syndrome or Rotor syndrome. By this point of time, I hope you are aware. In Dubin-Johnson syndrome, patients are going to be having a pigmented liver, whereas in Rotor syndrome, patients are not going to be having a pigmented liver. However, the common finding in them is that both of them are going to be having elevated concentration of conjugated bilirubin. So read the question carefully, whether they are talking about unconjugated or conjugated. Accordingly, differentiate whether it is an adult patient or a child, or is it a question making a mention of pigmented liver or a non-pigmented liver. That's how you are able to crack a question pretty comfortably over here. The other thing that I asked in the exam is a guy is going to be having a history of alcohol. He could be having the presence of a fatty liver. So he could be having the presence of a steatosis. The second stage happens to be steatohepatitis, and then you are going to be having a development of cirrhosis. When you're talking about steatohepatitis, you're going to be having the presence of those fatty or droplets or fatty globules inside the liver. And at times the patients are going to be having Mallory-Denk bodies. Guys, just answer for me, what is the composition of the Mallory-Denk bodies that are present over here? What's the composition of the Mallory-Denk bodies? Can somebody just let me know what is the composition of the Mallory-Denk body? Yes, you got a question in the exam recently also with this. Of course, they always ask you a question on liver and they talk about hepatocytes and hepatic sinusoids and portal tract, and they talk about, January 23 question was about Kupffer cell, if you remember that. So macrophage in the liver is given the name of a Kupffer cell. So yes, you are familiar with the fact. Very good. Yes, Dr. Aftab, it is cytokeratin 8 and 18 is what I want to remember, my friend. It's cytokeratin 8 and 18. That is going to be the composition of the Mallory-Denk body. Cytokeratin 8 and 18. Earlier it was called by the name of Mallory-Hyaline body, right? So most of us know about that particular fact. Having said that, we are sometimes asked a question on iron overload, which is given the name of hemochromatosis. Iron overload can be responsible for causing a trouble at the level of liver or the cardiac tissue or other organs. And you are going to be picking up with the help of what kind of a stain? Yes, Prussian blue. What's the name of the reaction? Pearl's reaction. How will hemocytin appear? It is going to be giving you a bluish appearance. So iron overload condition which is going to be associated with hemocydin deposition, is what is going to be seen as a feature of Prussian blue. That's what is going to be easy for us to recall. Having said that, you can be given a question, and that became a question. I mean, last 4 exams, I mean 3 exams gave you that kind of a question, wherein the patient was having the presence of what is given the name of a cataract. So the patients were having the presence of a cataract, they were having the presence of the Kayser-Fleischer ring, and in their hepatocyte, I mean in their liver biopsy, they were having the presence of copper deposition. So they were primarily talking about a patient who was suffering from Wilson's disease, and therefore these patients were having a problem at the level of the copper metabolism. So the copper in the free form is going to be going out from the liver, and that is what is going to be having a trouble over here. So that is going to be a feature of Wilson's disease. So iron metabolism problem, that is hemochromatosis. I mean, you can always get over here something like the presence of bronze diabetes, if you recall that from your discussion of path and medicine videos. Wilson's characterized by copper overload condition, that is what we need to have an idea. And of course you are going to be talking about that as an opthal question, the sunflower cataract, right? Having said that, we are talking about nutmeg liver, very commonly asked question, in which you are going to be having a variegated appearance of the liver. So you're going to be having a dark area which is consisting of the dead cells, and you are having the lighter areas, that means the living areas, because of the presence of the periportal cells. So the dark are the centrilobular or the perivenular cells, whereas the periportal cells are the living cells, and that is what is going to be seen in case of chronic venous congestion of the liver. Chronic venous congestion of the liver seen in a patient who's going to be suffering from right-sided cardiac failure. Right-sided cardiac failure. That is what we need to be remembering over here. This is not Dubin Johnson, my friend. That's the point that I just wanted to be familiar with over here, right? So this is what we need to have an idea so far as nutmeg liver is concerned. So they can ask you the cause, chronic venous congestion. They can ask you the clinical cause, that's going to be right-sided cardiac failure, or they can ask you a question regarding the appearance over here. So the dark cells are going to be either the dead cells, and the living cells are going to be having a lightish color. Then we talk about hepatocellular carcinoma. I mean, this particular variant is loved by the examiners because of the fact, one, it is going to be having the presence of a central scar, stellate scar is what you find over here. Then fibrolamellar variant is important because it is seen in relatively younger patients. You also find that these patients are going to be having alpha fetoprotein levels which are going to be normal. We also need to be familiar with the fact that these patients are not going to be having an association with a lot of other risk factors like hepatitis B and alcohol. So that is what you need to be familiar with so far as the fibrolamellar variant is concerned. However, if I'm talking about the routine, I mean hepatocellular carcinoma, the problem that you see in case of elderly people, you associate with people who are going to be having a history of alcohol consumption, or patients who are going to be having chronic hepatitis B and C, or patients having metabolic disorders like alpha-1 antitrypsin deficiency or Wilson's disease or hemochromatosis. So those are the risk factors that you are having over here. You also need to remember that hepatocellular carcinoma can be seen also in patients who are going to be having a fungal infection. And if I'm talking about a fungal infection in the patients, the fungal infection that we need to remember in these patients happens to be the fact that patients are going to be having consumption of peanuts, right? You remember the fact, aflatoxins. Hepatocellular carcinoma, aflatoxins are what I want to remember, which can be responsible for causing a development of the cancer in the patients. Clonorchis sinensis, I mean, that is not with hepatocellular carcinoma, but you need to remember the fact that this is going to be associated with the development of cholangiocarcinoma, my friends. Cholangiocarcinoma, NEET PG question. They already asked you this kind of a question 2 times earlier in your screening exam, but then just remember the fact clonorchis sinensis associated with the biliary duct cancer. CNS tumors, all-time favorite of examiners, and they're pretty easy for you to remember because one of the examples of tumors that you're given in the exam is glioblastoma. So you see the tumor over here, cerebral hemisphere. Tumor goes into the opposite cerebral hemisphere as well. That's a tumor which is going to be given the name of a butterfly tumor. Butterfly tumor, right? Butterfly tumor. Now glioblastoma is an example of benign or malignant, for sure a malignant tumor. I mean, you see the part of the brain affected, such a bad tumor. And because it is an example of a highly aggressive tumor, so you need to remember the fact it's an example of a grade 4 tumor. 2 years back, they asked you this question. Glioblastoma is an example of a highly aggressive grade 4 tumor. That is what you need to remember over here. Microscopically, what would I find in the histology of a glioblastoma? I would have the presence of a serpentine necrosis. Let me just show you that fact. This is going to be an example of a serpentine necrosis that you have in the patients, and the patients are going to be having a pattern which is going to be given the name of a pseudo-palisading. So around the necrosis, if the tumor cells are going to be having a fence-like pattern, that's going to be given the name of a serpentine necrosis or the pseudo-palisading pattern. That is what you associate with glioblastoma. Multiforme is not being added over here now. I mean, we are actually using the term only and only glioblastoma over here, right? The other example of a tumor that we talk about over here is a meningioma. Meningioma, what is the site of origin? It is going to be arising from the meningothelial cells. Which type of meningothelial cells? Typically, it is going to be arising from the arachnoid matter. And the question will talk about the fact the lady, she's going to be having the presence of features of increased intracranial tension or cranial nerve palsy, or she's going to be having seizures. And then she's going to be talking about the fact that the question is going to be talking about the dural tail sign. So this is going to be meningioma, and we already talked about the fact meningioma. What do you get over here in the histological finding? Yes, concentric rings of calcium deposition. That's going to be given the name of semoma body. So that's going to be an easy question. You just need to be familiar with over here. Dr. Naresh, if you can just remember and revise for me, since you made a mention of temozolomide, how does it act, my friend? How does it act? Okay, pilocytic astrocytoma, pediatric tumor. This is going to be an example of a tumor arising in the cerebellum. Yes, that's the channel you're watching out over here. It is going to be having the presence of a cystic mass over here. What you also need to remember over here is the patients are going to be having a cystic mass right over here. So that is going to be an example of a pediatric tumor arising from the cerebellum. That's going to be an example of a tumor that is going to be pretty commonly seen in case of children. That is what you need to remember over here. The other important example of a tumor is a medulloblastoma. Medulloblastoma is a malignant tumor. Medulloblastoma is a malignant tumor, bad tumor, highly aggressive in nature. At the same time, it is going to be having an association with the fact that the patients are going to be having the presence of tumor cells in their CSF. So that is what you associate with the development of a drop metastasis, right? Drop metastasis. We then talk about schwannoma. Schwannoma would be an example of a tumor. The other name for schwannoma that can be given in the exam as an example of maybe an ENT kind of a question. They may make a mention of something which is going to be given the name of an acoustic neuroma. So you're going to be having the presence of, typically remember the fact, antennae A, antennae B areas, hypercellular areas, antennae A areas, hypocellular areas, antennae B areas, and then you're going to be talking about something that is going to be given the name of a structure that's going to be given the name of a Verrucke body. Remember the fact Verrucke body? You're going to be having the presence of nuclear phase structures over here. That is what you need to remember, what is given the name of Verrucke body. So schwannoma, acoustic neuroma, neurofibromatosis, 2 gene involvement, presence of antennae A, antennae B area, presence of Verrucke body, all that what you just need to remember over here from the perspective of your exams, right? Alzheimer's disease characterized by the fact patients are going to be having the deposition of the tau protein, and the tau protein, apart from the fact the patients are going to be having the presence of which of these? Yes, you are going to be having A beta tangles in these patients, A beta tangles. Lewy body is what you see in a patient suffering from Parkinsonism, right? Parkinsonism. If I'm talking about prions you associate with conditions like, let us say, the C. Creutzfeldt-Jakob disease, so CJ disease, or the bovine spongiform encephalopathy. So prion disease is what you are going to be associating with prions, right? Lewy body, Parkinsonism. Tangles, A beta tangles. Hirano body is what you are associating with Alzheimer's. Remember, donepezil is going to be the drug of choice. And what you're finding in these patients is cerebral atrophy. So you're going to be having the gyri which are going to be becoming, when there is an atrophy of the brain which can be picked up with the help of MRI, or clinically you would have a patient who's going to be having a deterioration in the mini mental state examination score. That's going to be the other important thing. So far as the genital tract is concerned, less questions asked in the exam. Nonetheless, be familiar because usually this is a topic more often covered in surgery. So far as the genital tract is concerned, female genital tract covered in gynecology, of course. But then just remembering and revising the fact, leiomyoma is an example of a tumor. Can you just see the example of a leiomyoma which is also being given the name of a fibroid. This can be an example of a submucosal growth, or this can be an example of an intramural growth, or this can be an example of a subserosal growth. But just remember the fact that leiomyoma is going to be associated as uterine fibroid, and that's an example of a benign tumor, right? If I'm going to be talking about chocolate cyst, very commonly asked question in the exam, seen in a patient suffering from endometriosis. So you're going to be having the ectopic endometrial tissue typically present in the ovary. During the cyclical changes, this is going to be having a bleeding as well, and that's going to be responsible for causing a blood accumulation over here in the ovary and the resulting in the formation of a cystic mass. So that is going to be given the name of a chocolatic cyst, right? We need to be familiar with the fact that teratoma. Now that's a very, very high question asked in the exam. Teratoma, which is going to be arising from the totipotent cells. It is going to be having the origin of the tissue which is going to be rising from more than one germ cell layer. So you can easily make out the presence of something like the tooth-like structure. You could be having the presence of fat and sebaceous glands. You could be having the presence of hair. You can be having the presence of the tissues associated with, that means ectoderm, the mesoderm and the endoderm, and therefore it is going to be given the name of a teratoma. Teratoma in the females, in the ovarian tissue, it is going to be given the name of dermoid cyst. Please be familiar with the fact that the common site of origin of a teratoma happens to be the gonads, and the extragonadal site happens to be, can you just answer for that for me in the chat box? Yes, you're going to be having the extragonadal site of a teratoma. That's going to be typically answered in the mediastinum, right? So that is what we need to be familiar with over here. Yes, Dr. Isha. Yes, Dr. Kishore. Yes, Dr. Appu. Yes, Dr. Krishna. Yes, Dr. Aftab. Very good. So you just need to be remembering about that particular fact. Having said that, there can be a situation when the patient is going to be suffering from either a breast cancer, or a patient suffering from a colon cancer, or most commonly a patient suffering from a stomach cancer, in which the cancer cells can migrate and cause involvement of both the ovaries, So bilateral ovarian enlargement. When you have a bilateral ovarian enlargement, most commonly caused because of a stomach cancer, this is going to be associated with the term Krukenberg's tumor. Krukenberg's tumor. And when you talk about Krukenberg's tumor, this is going to be a typical picture that they just give you in the exam. So just need to have a mental idea about the bilateral ovarian enlargement. And at a microscopic level, what the patients are going to be having is presence of mucin droplets, which are going to be pushing the nuclei on one side. So that is going to be giving or associated with the term the signet ring appearance. So that is going to be associated with the Krukenberg's tumor. Easy but important question that you need to remember for your exam. Seminoma. The question will talk about the fact that there is a guy who happens to be a middle-aged male. He was having the presence of a testicular mass. Now testicular mass in case of a male, especially in case of a middle-aged to elderly male, should be taken to be an example of a tumor unless ruled otherwise. So we are going to be the question does make a mention of the fact. I mean, that's exactly what the question that they gave you. So middle-aged guy who was having the presence of a testicular mass, and this guy was also having the presence of an enlarged lymph node, the left-sided supraclavicular lymph node. So that means a virtuous lymph node. So testicular mass with a lymph node suggestive of the fact that we are dealing with something like a testicular tumor. And if the question says a middle-aged individual, we are thinking definitely in terms of a seminoma. I mean, in case of children, you usually are going to be having a yolk sac tumor. In case of elderly, you have a lymphoma. But in case of middle-aged individuals, you are going to be having a seminoma. Now, seminoma is an example of a germ cell tumor, which is good in the sense because it is highly responsive to chemotherapy as well as radiotherapy. So, somewhat associated with, I would say, a better prognosis. Now, seminoma characterized by the fact that you are going to be having the presence of cells, and these cells are going to be having a presence of a very large amount of glycogen in them. So, they are going to be having the presence of clear appearing cells. Of course, you are going to be having lymphocytic infiltration in the septa. So clear looking tumor cells having the presence of lymphocytic infiltration in the septa is what we need to remember so far as the seminoma is concerned. What is the counterpart of a seminoma that we get in the ovary? Yes, that is going to be something like very good. A lot of you are already talking about the markers over here. Is seminoma going to be having alpha fetoprotein levels to be raised? The answer is no. It is rather going to be having positivity for PLAP. The markers are OCT4, right? 3 and 4, right? That is what you need to remember over here. So this is going to be the seminal histology. Alpha fetoprotein level are normal, but PLAP, OCT4 are going to be elevated, and therefore very characteristic polyhedral cells which are going to be having a clear appearing cytoplasm, and you are going to be having the presence of lymphocytic infiltration in the septa. That's what is going to be seen in case of seminoma. Counterpart of seminoma happens to be, yes, very good Deepshika, you answered that correctly. That's going to be a dysgerminoma. Benign prostatic hyperplasia, standard thing that you need to remember. The guy is going to be an elderly male who is going to be having a problem in urination. So there's a problem in starting the urinary stream, there's a problem in stopping the urinary stream, and you just need to be familiar with for the fact that this patient is going to be having the development of a tumor because of the fact the enlargement of the prostatic tissue under the influence of dihydrotestosterone that causes the compression of the urethra, and that is an example of a hyperplasia. But as I told you earlier, this is perhaps a very few examples of hyperplasia which is not going to progress to a cancer. Not progressing to cancer. We already had a discussion about the medical management of this kind of a tumor, this kind of a condition. Do excuse me on the word tumor time and again. I mean, pretty close to 3 hours, and maybe so therefore the hypoglycemia taking a toll over here. We need to be familiar with the fact that 5-alpha reductase inhibitors, drugs like finasteride, dutasteride, or the example of uroselective alpha blockers like tamsulosin might as well be helping these patients out, right? That is what you need to have an idea over here. Of course, if I were to talk about something like carcinoma of the prostate, the question that they ask you in the exam for the screening exam is concerned is, it's an example of an androgen dependent tumor. At the same time, you are going to be using a grading system for carcinoma prostate. That kind of a grading system is what is going to be given the name of Gleason staging. So Duke staging is what you use for colon cancer, Gleason staging is what you are using for prostate cancer. That is what they'll have to ask you as a question in the exam. So far as the breast tissue is concerned, examiners are going to be asking you questions with respect to the kind of breast tissue which is going to be having a very good prognosis. So this is going to be the example of the breast tumor which is going to be having the presence of the ER positivity. I mean, you are familiar with what is going to be given the name of. You can just help you remember the fact it's a luminal A type, relatively slow growing with respect to the other variants, but luminal A type of a cancer, breast cancer, is going to be having one of the better prognosis. The kind of breast tumor that you associate with the term the breast mouse is going to be a fibroadenoma. If I'm talking about the breast tumor which is going to be having a very good response to a drug like Herceptin responsive breast tumor is going to be the one which is going to be having a positivity for HER2/neu. That is a question asked in the exam. Then they talk about an example of a breast cancer that is going to be associated with bilaterality. Bilateral breast cancer is going to be a feature that you associate in a patient who is going to be suffering from lobular carcinoma. I mean, otherwise, obviously, breast cancer would be an example of a highly specialized topic, and if we just go by the discussion of what the surgeons are going to be talking about, they can talk about hours and hours on the same topic, but just giving you a very, very super brief review with respect to the most common question that they put up to you in the exam. So luminal A1 is going to be having the best prognosis. Remember, the chemotherapy receptive, the Herceptin receptive or the trastuzumab receptive breast cancer is going to be the HER2 new positive breast cancer. The bilateral breast cancer is going to be the lobular cancer. That is what you need to have an idea. And the breast mouse, obviously, which is one of the very common presentations in case of young females who are going to be coming to you because of the presence of a breast lump is going to be fibroadenoma. That is what you need to remember over here, right? So close to 3 hours of our discussion over here, and I think we have touched about almost every topic without sparing any of them. But I repeat the fact that this is not going to be something which is going to be a substitute for you watching the main videos or you not watching the Cerebellum rapid revision over there. But at the same time, just a very quick review with respect to what are going to be the most important things which are going to be asked in the exam. On that note, we are going to be having regular discussions so far as the FMG June students are concerned. For all the other people appearing for the FMG exam, maybe sometime later, let's say in December, we are going to be having a very structured kind of a discussion in the app. But this was the first example of a live-in session wherein we just wanted to have a highlight about a quick recap of the important points, and as well as be assured of the fact that since we have promised you that live sessions are likely to be conducted, so we'll stay by our words. A lot of you are asking questions. Okay, people are talking about the fact you can ask the doubts, man. We are going to be available so far as we'll try to have a group with you. Either you can mail us the questions or you can let us know with respect to the doubt clearance. The social media profiles are always open, and I will be more than happy to answer your questions. Thank you so much, everybody. And then that's the only thing that I wanted to be familiar with. Just few words of pumping up the adrenaline, and that is don't talk to too many people, because most of the people are not going to be supportive of you either physically, either financially, or even so that motivationally as well. Don't share any of your plans with you. That doesn't mean that you don't talk to people. Of course, talk to them, but talk to the right kind of people. Instead of verbally saying about something, it is better that let your results speak for them, right? So there are always going to be a naysayers, and I keep on talking about that fact that I did that kind of couplets which we did make a mention on the fact in the Instagram session as well, कि किसी और से सुनोगे तो हमें बुरा ही पाओगे, किसी और से सुनोगे तो हमें बुरा ही पाओगे, कभी पास आके मिल के देखना, दिल खुश करके ही जाओगे, right? So just keep on very much focused with your preparation. Make sure that you're keeping your revisions intact. Make sure that you have a proper study schedule. We'll be sharing the discussion and the study schedule of the in-sessions, live sessions with you very shortly. Make sure that any live session that you're attending, you are a bit prepared for it. Don't get disheartened if you're not able to answer the questions. Just make sure that it is a kind of a revision. Thankfully, before the exam, somebody could show you the mirror that this is what you have to revise. If you are already knowing about it, do encourage yourself, do give a tap to yourself that yes, you know about it. But at the end of the day, the purpose is that prior to appearing in an exam, you should be having the most important things on your tips, right? So this is what we are going to be having a discussion about, and time permitting, we shall be perhaps catching up with another session shortly, not of this particular subject, but of course the other subject, and we shall be sharing the schedule with you, right? So this was, I think, a good enough investment of 180 minutes on your part, which is likely to be yielding some good and bright results. At least if not anything, it would have boosted your confidence with respect to the fact that we have touched almost every topic, and a lot of you who have already prepared for the exams would feel good about the fact that you are able to recall at least a good percentage of the chunk of the information. In case there was something which was not able to you, you are not able to get anything, you can always have a rerun of this, maybe at a still higher speed. But make sure that you are revising that stuff, because revision is what is going to ensure that your results speak rather than your words, right? As always, do take very good care of your health. Make sure that you are masking up yourselves properly because of the increasing incidence of the infection these days as well. And as well, always best wishes from everybody over here at the team, right? Good night and take care. Bye-bye.